Mehmet, how are you, Mehmet?
Good to see you.
Good to see you. Great to see you. How are you?
Good.
Hello, Kim.
Doing well at home.
No, I'm not at home. I'm at my
Kim?
office. You know that Saturday and Sunday are not weekend for us. It's just Friday. So I'm in my office in the university.
Can you hear me?
Yes, Ed, we can hear you very well.
Good.
Good morning, big boss.
Good morning.
Good morning.
Mark, I think I'm going to come on that
Mario.
side.
Mario, you're on mute.
How are you, Ed? Are you okay?
I'm okay. I'm trying to get Mario to get off of mute. Unmute yourself.
Let's see if I can help
Professor
you.
Mario, mute.
Maybe I'll be sorry.
Unmute, please.
تعال بس نفس المسج ايه ده؟ هو مش ممكن هو ده فتح حاجه بس عندك مش نفس
Ed, where did you see Mario?
I see him lower left.
Okay, I got him, and he is. I'm just going to mute him.
Mario, how is that cigarette?
Hi. Good morning. How are you?
How is the cigarette?
I went yesterday here too, but without camera. I'm at home. It is real feel -10 here in Ireland.
Hi, Mario. How are you?
Fine, thanks. And you?
Hey. You are smoking. I
Yes,
can offer
of course.
you Turkish coffee. Turkish coffee.
Argentine coffee. No, Colombian coffee.
Good. Very nice.
الزنقه دي بتخلي اعصابي تتلف ببقى مش عارف اتصرف يعني احنا بنتكلم بقالنا ساعه وفي الاخر زنقنا نفس الزنقه ولا كنا عندنا ودي
While we're waiting, Salman, can you talk to us a little bit about what you and Zan have been doing with regard to the Chinese participation?
دي مع البرزنتيشن حاجات كنسيه
Just unmute yourself. Zen, can you hear us? Yes, Zen, can you hear us?
Yeah.
So
Hi.
Zen will tell us what he's done for us. It's, he's our friend. We are together in the World Federation Spine Committee, and we have done a course in Beijing, and we've done a few webinars together. He's a very good friend, and Zen has been helping in the background to transmit all this in China. Zen, would you like to tell us what has happened in China for this meeting? Thank you.
Yeah, it's my pleasure.
If you could tell us how you have done it, how many translators and how many people connected yesterday?
Yeah. Because in China, very few neurosurgeons perform spine surgeries. So, but in recent years, more and more neurosurgeons are involved in spine surgery. And in these several days, I have transformed this meeting lovely into website. One website is focused on neurosurgeons, and another website is for orthopedic surgeons. So if they're interested, they can watch the meeting. And I also organized 10 of our young doctors whose English are much better than mine, and they can perform a translation at the same time for our Chinese doctors. So yesterday, about 600 Chinese surgeons have visited our website to see our meetings.
1,700 is what you're saying.
Yeah.
Okay, brilliant. And 5 translators or 7 translators yesterday.
Yesterday about 5 translators, and today another five translators. They are all young surgeons in our department.
Brilliant. I think you guys have done a great service for us and for them as well, and obviously bringing all these top guns of spine to China is great fun. We are grateful for that, and we love it if you continue to help us and join us in this venture.
Yeah.
Okay, has Rick Fessler joined? Do we know? Let me call him.
Oh, no.
Well, Nurulai, come here. Nurulai, not come here.
Professor Fessler is not picking up the phone. I hope he's awake. Anyway, I think if he's late, then we'd start with Professor Chen, if that is the case. But if he's there on time, then we'd go with him. Then, okay, sorry, Ed, yes.
He's got 6 or 7 minutes.
Yeah, we'll wait. Then, have you checked your slides and you're okay with your slides? You can share your slides now and just check while we're waiting. And then if Rick comes in, we unshare, obviously. Brilliant. That's fine.
Professor Salman?
Yes,
Richard
Kim?
Fessler not come here?
Sorry,
Richard
Kim, what did you
Fessler.
say?
Richard
Rick
Fessler not come.
Yeah, he hasn't joined us yet, but I've messaged him. He's not picking up the phone, and he's delayed. Then we'd start with Zen, our friend from Beijing. But if he's there on time, we still have 7 minutes. I usually join a minute or 2 before. So it's now with so many webinars going on, people join quite late. So we give him time. Kim, what's the situation in Korea?
Yes, Korea now some doctor stroke. It's some with some new revolution of the coronavirus again, and maybe some trouble with the government and doctors. I think that maybe
So is that you sharing your slides?
Can you see them?
loud.
Yep, they're
Can
fine.
you see them?
Yes, yes, they're fine.
Okay. So I will stop sharing. I will just trying them.
Yeah, that's fine. Is Ruli here as well?
I haven't seen Ruli.
So we will.
Just like
Dr. Ruli,
I will sharing my slides. عايز اوقف الشيرنج.
Ruli?
I don't see Ruli here yet.
I don't see as well.
So Imad is just calling him.
قفل اكيد.
I think that maybe first, today is the second day and final day. Firstly, give a talk from new president, and we'll start the minimally invasive spine symposium today. It's okay?
Yeah, I think you start with the session. Obviously, Nurulan should introduce you and Ruli before we start, if Ruli is there. Nurulan, are you there? Can we hear from you? Yes, good. Okay, the other important thing is that we all hosts should mute ourselves. Because yesterday what was happening, because we all wanted to become the host and everybody is becoming the host. And then while we were having the poll, somebody was clicking on the poll, replay the poll by mistake. And because of that, we could not play the poll yesterday. So if at all possible, when we are doing this, we're having the poll for the single question, then please, we must make sure that we don't click on replay the poll as a host. Because if you do that, it's going to, all the data that's been collected will go away. So
Salman, who is announcing the last 3 chapters? Sorry, not chapters, but the papers which were selected.
Everybody is
It's
giving.
gonna be Mehmet and Ed.
Okay.
We will hand on to them, and that's what is in Nurulan's schedule.
Yeah. Okay. And also in the awards, there will be certificates for all the keynote speakers and certificates for all the speakers. All the moderators will be acknowledged as well. And it's basically making sure that everybody who's done any kind of work is acknowledged. It's okay.
I just emailed Fessler
Yeah, I'll see if he has.
and
replied.
CC'd you and Imad.
Yeah, he hasn't seen my message yet.
Professor Richard Fessler, come here.
Not yet. So we have 2 more minutes. We'll give him 2 more minutes.
Two minutes is a lot.
Anyhow, if Ruli doesn't log in, you will start him, right? After Nurulan introduces you, and then we can start.
Yep. Are we starting?
No, we have a couple of minutes to go. So I think what we will do is we will switch on the microphone for people who want their microphone switched on for a couple of minutes, and then we switch off everybody's microphone. I'm sorry.
Okay.
And
That's good.
the important thing is that we don't make the mistake again of maybe replaying the poll or anything else.
By the way, the numbers from China are really amazing. Wow, it's incredible.
It is. I didn't think
6,000.
there would be, yeah. I didn't think that 6,000, 700 spine
Amazing.
surgeons, would be listening to a conference, but, they are very keen. And, obviously with the literature they read, all the people who write the literature are giving the talk. So why not?
I was checking how many neurosurgeons in China in 2009, and it were about 30,000.
And you
Yeah.
don't have the number of the orthopedic surgeons. That should be like 100,000 or more.
But how many doing spine is the question. Maybe
I don't
Zen,
know.
would you know how many altogether spine surgeons in China?
We have the 20,000 neurosurgeons and about 50,000 orthopedic surgeons. And among orthopedic surgeons, there is 10,000 spine surgeons.
Oh,
13,
thank you very much
13.
for what you're doing.
Then
Okay, I
Paolo
think
is
that maybe now
thanking
we'll
you there.
start. 12 p.m.
Okay,
Let's
no
start now.
problem. Nurlan, could you kindly introduce our friends? We'll start.
Yep. So good
Ruli's
morning.
not there, so it's just Kim.
Oh, okay. So good morning, good afternoon, and good evening to people all over the world for our day 2 of our Virtual World Spine 2020. We're going to start off with Professor Hyung Sung Kim to moderate the first session.
Yes. Good morning, good afternoon, good night, everyone. I'm Hyun Sung Kim from South Korea. This time is the second day of the Virtual World Spine. Today we will mainly discuss about the minimal invasive spine surgery. This session will moderate with Ruli and me. And firstly, I will introduce Professor John Chen. First session we'll have two main speaking. First, John Chen will give the lecture of the resection of the cis primary spine tumors. Professor John Chen.
Okay.
Yeah.
I'll share my slides. It's a pleasure to have the opportunity to share our experience. And in 1988, Tomita has proposed that primary spine tumors should be removed totally in the manner of totally unblock. And with this standard, the recurrence of the primary spine tumor recurrence was decreased dramatically.
Zen, sorry, could you reshare your screen, maybe unshare and then reshare, because we can't see your
we cannot
slides.
see your slide.
Okay, I'll do it again.
Yes, please.
Is it okay?
Still cannot see. No, still cannot
Not
see.
yet, we are waiting.
I cannot see it.
It says it's starting to share.
Yeah. I'll share it again. Is it okay?
Is yours slide, PPT slide?
Yeah, this is my slide. Is it okay?
No, we can't see your slide.
No, we cannot see.
What's the problem?
I think you can try once more.
Is it okay?
No. We cannot see.
Then maybe what you could do is, sorry, what you could do is you could disconnect, go out and come back in. Sometimes it happens.
Yeah. maybe I just leave and
Yeah, just disconnect, go, and please come back.
Dr. Ruli, come here.
Ruli is here, so we can have Ruli.
And also Professor Richard Fessler, come here.
Not yet. Okay, Zan has come back in.
Rule is there already.
Yeah, and Zan has also joined. So
Correct.
brilliant.
How about
Ruli?
Okay, it's good.
Good.
It's
Let's
okay?
go.
Zan, it's good.
Perfect.
Yeah,
Perfect.
thank you. Sorry about the website. My topic is about the C2 primary vertebral body tumors. Tomita has proposed the surgical standard of primary spine tumors. We should do it totally en bloc spondylectomy and to reduce the recurrence rate of this kind of tumor. And also with the WBB system, surgical system, we can do some process plans for the spine tumors, especially for the cervical spine tumors. But such kind of this case is a recurrent cervical spine tumors involved C3 and C4. And according WBB surgical system, we perform the anterior and posterior surgery and cure the patient. But in upper cervical spine, there is some problem because the anterior column of the cervical spine is hard to reconstruct. The ordinary mesh and the internal fixation system is very improper, difficult to reconstruct the C1, C2 anterior column. For example, in the literature, this is a C2 primary tumor, though the tumor was removed totally, but with the mesh, the reconstruct of the anterior column was not so stable because there's a leak the sufficient support under the C2 lateral mass on bilateral side. So the internal fixation failure may happen in this kind of circumstance. 3D printed technique has been used in medical field for many years. And in 2012, the first case of reconstruct C2 vertebral body with 3D printed processes was reported in China. And with this technique, another hospital even reconstructed 6 levels of cervical spine with this kind of 3D printed processes after the whole tumor resection. In last 2 years, we have used this technique to perform tumor resection of upper cervical spine in 10 patients. This is patient data. Among these patients, 8 patients are male, 2 are female. The age is range from 12 to 56. And the histopathology of the tumors, among them, 8 cases are chordoma. 1 case is aneurysmal bone cyst. Another one is hemingeal parenchyma. And the involved levels, in 1 cases, C1, C2 are involved. In 8 cases, C2 involved. In 1 cases, from C2 to C4 are all involved. And the treatment procedure, anterior out of the patient, we perform the anterior in 9 cases. The anterior procedures are transoral, and in 1 cases are high retropharyngeal. And all of the patient have been receive radiotherapy before or after surgery. Complications. In 1 cases, the door are teared open, and there is we have to perform lumbar drainage to treat the to avoid the CS leak. And another patient suffered sudden bleeding from vertebral artery and died after operation. And 1 patient, the tumor recurrent in 1.5 years. This is several cases we performed in our series. This is a male, 38 years old. He suffered hemangiopericytoma in C2. CT scan showed the C2 vertebral body are destroyed.
我能明显的感觉到所有的老外都在一脸懵，啥什么鬼
MRI showed the tumor contrasted obviously. And before operation, we use the CT scan data to design and build the 3D printed processes. In the operation, first, with the posterior procedure, we remove the posterior structures of C2, and then with the anterior transoral approach, we removed the residual tumor and also the whole C2 vertebral body and implant the 3D printed processes. This is another case. He's a male, 56 years old. It's a chordoma on C2. On MRI and CT scan showed the destroy of the C2 vertebral body. With the posterior and anterior approach, we totally removed the C2 structures and also the tumor, and reconstruct the anterior column of C2 with 3D printed processes. This is another C2 chordoma. On MRI, we can see the chordoma was rather large in size. And with CT scan data, I designed the 3D printed processes of C2 vertebral body. And also in this case, I designed the C2 lateral mass. And also we can design the screw projection and before operation. In the operation, with the first posterior approach, we remove the posterior structures and implant internal fixation system. And in the second stage, we perform the anterior transoral approach to remove the tumor and implant the 3D printed processes. This is 6 months later, the CT scan showed the processes. This is another case, 12-year-old male boy. He suffered C2 aneurysmal bone cyst. And from CT scan showed the C2 vertebral body are totally destroyed by the tumor. In the first posterior approach, we remove the posterior structures and the tumor and plant C2 and C3 pedicle screws to stable the cervical spine. With the CT scan data, we design and build the 3D printed processes. Then in the second anterior approach, transorally, we remove the whole tumor and the C2 vertebral body and implant the 3D printed processes. This is an intraoperative CT scan showed the 3D as a processes and also the screws. This is a 1 year follow-up of the boy, and the MRI showed there is no residue of the tumor. CT scan showed the internal fixation system is stable. This case is most challenging in our series. It's a recurrent chordoma from C4 to C4, C2 to C4. He is a male, 48 years old. He has performed four decompression surgeries before, and the tumor recurrented. From an MRI showed the tumor was rather large and involved C2 to C4 and enveloped the vertebral artery and also the nerve root, compressed dural. From CT scan showed the vertebral body of C2 to C4 are totally destroyed. With CT scan preoperative, we reconstructed we designed and built the processes 3D printed. In the operation, first with a posterior approach, I removed the tumor and dissected the vertebral artery from bilateral side and protected the vertebral artery. It is important to dissect the vertebral artery from the tumor. Then, with a retropharyngeal approach, I remove the resident tumor and C2, C4 vertebral body. And this is the facet joint of C2.
Professor Chen, please summarize.
Excuse me?
Summarize, please.
Then, then after remove the facet joint, we can see the vertebral artery with 3 segments. And we push the tumor are also all totally removed. And then the processes are implanted from the anterior approach. And this is a 1 year post-operation follow-up. We can see the internal fixation is stable, and there's no recurrence of the tumor. There's no neurological deficit of the patient in the patient. Take-home message: the upper cervical spine total segmentectomy should be done, and a personal 3D printed vertebral body can be used to reconstruct the upper cervical spine. And bone effusion rate and tumor current rate need to be followed up. Thank you.
Thank you so much. Professor Richard Pestel, come here.
No, he hasn't. So I think we will close this session. And if he comes in another session, we can always include him later on. I think we go on to the next session. Noor, thank you, Kim. That was very good. And Zen, that was brilliant. So anybody who's got questions, they can email on the email that's written on the chat. And we'll pass that on to Zen, and then we can reply that, and we can put it on the website tomorrow. So you all are most welcome. So I'm grateful, Zen. Kim, we are grateful. Thank you for moderating this session. So Noor, can you introduce the next two moderators?
So we have our third session for this World Spine. For this next session on minimally invasive spine surgery, I'm going to introduce Professor Edward Benzel from USA and Professor Mehmet Zalidi to moderate the session. I would also remind the people who have to present their papers to have their presentations ready so that we can go on from there.
Is Richard Asseker on the line? Is he here?
He's not yet here. So
yes, I'm here.
So sorry, Asseker is here. I apologize.
Great.
Hello.
Our first speaker for this session is Professor Asseker. He is a professor of neurosurgery at Hôpital de France and is highly regarded for his contributions to neurosurgery and to spine surgery. And again, he's going to talk about OLIF in his keynote address. Professor.
Thank you, Ed. So I will share my screen. Here we are. Is it shared now?
Yes.
Yes. So my topic would be about a new access. I mean, not that new now. We've been doing this for almost 7 to 8 years. It's an anterior to psoas arthrodesis, and I'll show you the rationale of that, the indications, and the tips and tricks. So this is my content in this lectures. I will go through step by step. So what is an OLIF? An OLIF, it's oblique lateral interbody fusion. It designed an anterior to psoas axis. As you can see here, we have all the posterior, posterolateral, lateral interbody fusion and anterior to the psoas. All the axes are represented here. The OLIF is an oblique lateral to the body of the vertebra just in front of the psoas. You can see here, actually, what we need is to avoid the vessels anteriorly and also the lumbosacral plexus posteriorly. So we have to go through the psoas or anterior to the psoas. Through the psoas, it's called DLIF or XLIF, and anterior to the psoas is the OLIF. Why OLIF? OLIF is actually an interbody fusion. It restores the height and the lordosis better than posterior axis. You can also realign your spine by just anterior reconstruction. Could be a second step after a posterior alignment and stabilization for deformity. And also it's helpful in case of revision surgery while patient had multiple surgery posteriorly, and the only options for straightforward surgery might be anterior. So it is by definition a multi. It is by definition. I have a problem with my. It's a minimal invasive concept because, as you will see later on, we do not sacrifice any muscles. It's just splitting muscles and going through the abdominal wall to the psoas and the spine. So it's a direct access to the disc, and as direct to the disc, you can segmentally better reconstruct than posterior, and you can place a large footprint implant and with a higher fusion rate. Look at this spine on the left side here. On the right side, you have the spine positioned for all multi-level OLIF, and if you look posteriorly, you can see on almost the same spine and immediately after surgery, before getting the patient out, and you can see here how much height of the disc we obtain and how much lordosis we achieve compared to before. So this is the concept, and this is a rationale and the advantage of anterior access. Of course, there is some anatomical issues, and I will not go through detail because it's well known now. We have safe corridors, and we know that through the psoas, it's more risky than anterior to the psoas. Through the psoas, you are facing the lumbosacral plexus, especially in L4-5, and anterior to the psoas, actually, you're splitting the muscle posteriorly, and you are away from the lumbosacral plexus. But still, we have some details that some surgeons are not aware about, and especially the nerves that runs in the wall of the abdomen. By this, I mean you have the subcostal nerve. First, it's an intercostal nerve. It runs below the T11, T12 ribs, and those anterior branches of those roots are important for the abdominal wall. If you injure one of them, you get a pouch and you get abdominal atrophy. So also the iliohypogastric nerve, it runs also in between the transverse muscle and the internal oblique. And as a principle, once you split the muscles, you should never injure any of the structures between the transverse nerves and the internal oblique. I never use cautery, for example, monopolar cautery. I never cut with scissors. I just split the fibers and go. The ilioinguinal nerves also is also in between it's lower and in between the transverse and the internal oblique. Lateral femoral cutaneous nerve also, it's much more caudal, but it can be injured between the iliac crest and your retractors. So this has to be well known to avoid complications from the abdominal wall access. The genitofemoral nerve is always seen on the anterior aspect of the psoas. You have to have a direct vision on these nerves because it cannot be monitored anyway, and it's easy to identify these nerves and avoid any injury to the nerves. That it's mainly sensitive nerves, and you can get a perennial pain if it's injured. So let's go step by step through some of the details. Positioning the patient is usually on right lateral decubitus. I usually go left, but you can go in the concavity of a deformity eventually. You can go right or left, but it's easier to go left because the vein is on the other side. This is typically how we position the patient, and we draw on the skin. This is the iliac crest here. The disc level is here. No, this is the disc level here, and you can go oblique to the iliac crest for one level. You can have a multiple access from 5-1 till 1-2. This is the projection of the disc on the skin. Those are the directions of your levels, and this is the iliac crest here. So by an oblique axis, you have more alternative to go caudally to cranially compared to the D-left or compared to the X-left. Usually I extend the ipsilateral legs in order to shrink the psoas. If you flex it, the psoas is more flaccid, more covering the spine. By positioning the leg like this, I have more access to the anterior space between the spine and the psoas. The skin incision is according to the levels you're operating on. You can do one skin incision, or you can split your incision by 2 and split the muscle below. accessing is a retroperitoneal classic access. You split the peritoneum anteriorly. You can see here that, and we'll see it on the video, the genitofemoral nerve is well identified. Then there is a specific retractors today that allows you to have a better access to the spine, and then you start your discectomy. As you can see here, the psoas is lifted posteriorly, the lumbosacral plexus is hidden, and the genitofemoral nerve is protected. The only structure that could be injured is a sympathetic chain that it's not always easy to save. Discectomy, preparing the end plates and inserting a cage as you usually do in any interbody fusion tumors. So this is the abdominal wall here. As we said, you have the external oblique, internal oblique, transverse. It's split, not cut, and you have to make sure that you are aware about the iliohypogastric, ilioinguinal, and the cutaneous lateral femoral nerve. If you look to this video here, you can see how I split the muscle just by taking the scissors closed. I do not cut, and you can use your fingers or peanuts in order to get the layers of your abdominal wall open, layer by layer, till you get the transverse muscle and the peritoneal, retroperitoneal fat, like you can see here. The back is at the superior part. I'm placed ventrally to the patient. Here is, once you split the peritoneum, you can see here, this is the 3 layers of the abdominal wall, and it's typically minimal invasive. You see that you do not cut any, and you can see in the bottom, you can see the psoas and the genitofemoral nerve here. Then once you are on the psoas, it's important to identify the anterior aspect. Then you push the psoas posteriorly. You can see the ureter, the iliac arteries, even the iliac vein. And here we are at the L4-5 disc space here, and you can see the sympathetic chain here. It's not easy, as I said, to save the sympathetic chain. You'll see here, this is the specific retractors that we're using for that. And you can see the sympathetic chain after the discectomy is preserved, but we don't know if functionally the ureter is there. And you can go anteriorly to the spine. And this is one of the advantage of the anterior to the psoas, that you can disconnect the segment completely from the anterior longitudinal ligament. You can see you can go in between the vessels and the spine and disconnect in order to restore the maximum of lordosis if needed. So here, it's the sympathetic chain. You can see it on the top here. The peritoneal is there, and you have a safe corridor to your spine. And here you can see the cage placed in, and the sympathetic chain is already, but it's not always the case. I cannot always save the sympathetic chain. So you can do this on many levels from L5-S1 till L1, L2 if needed. The fluoroscopy is important to set, and usually I place it in a lateral position first, and then in AP, in AP, so it rotates for AP positioning. You have to make sure that your images are well well imaging actually a true AP and a true lateral. You can see here the spinous process are in the middle, and you can identify the two pedicles in order to insert your cage. This is a distractor, and then open the disc space, placing the cage, and you have your markers that helps you in properly place your cage. So typically, we need to make sure that we are not going through the foramen from the other side. The cage has to be orthogonal, and also it's very important to overhang the cortical bone from side to side to avoid subsidence. As a tips, when you bring your cage obliquely, one of the tricks is to go through the contralateral foramen. So it's important to rotate your cage during insertion and make sure that also you're going from one cortical bone to the other cortical bone. So the minimum length of a cage has to be 50 to 55 millimeter. Do not place a 35 millimeter cage. So this is the markers, and you can see those markers and identify the markers in order to place it properly. Let me show you some case. I have problems with my next, maybe it's better. So let's go through some clinical case. This is a typical and the best indication for anterior to psoas axis first, followed by percutaneous screw. And I will tell you why I do this. So this is the first step, anterior to the psoas, and placing a cage. You can see the height of the disc is restored. And then this is a percutaneous fixation placed in a second, in the same anesthesia, but in a second step. And this is before, then after, one step, second step. And this is our patient with percutaneous fixation posteriorly, anterior to the psoas anteriorly. Patient could go back home the next day. Another case, 51 years old lady with foraminal stenosis due to a degenerative spondy at L4, L5. You can see the post-op control here, before and after. Patient is up the same day. Those are the stitches. So maybe the main question is, why not a TLIF? TLIF, it's a very popular surgery. It's very easy, very safe. Why not doing a TLIF in this case? Actually, to make it short, TLIF is a good option for patients who had a low pelvic incidence, because you don't need a large lordosis. So TLIF in the best hands will allows you to restore something like 10 degrees maximum of lordosis on the segmental level. If you need more, especially in a patient who had, like on the right side, large pelvic incidence, you need to go anterior first and get the best of the lordosis restoration. So in another word, if you make your planning surgery, let's say this patient had the pelvic incidence of 55 degrees, his lumbar lordosis should be at 50 degrees mainly, and L4S1 has to be 30 degrees in a perfect world. If you do your surgery and you restore with a lordotic cage the 30 degrees needed between L4 and S1, it works. You have a good outcome. But if for some reason you get a hypolordotic instrumentation, especially when you do a TLIF, for example, this patient had to compensate and he will dislocate the level above. This is typically why OLIF is has to be mastered, because sometimes you are challenging a case that needs lordosis and you cannot achieve your lordosis by just a posterior access. I can give you an example here. This is a patient who had L4, L5 spondy. Surgeon has performed the laminectomy and fusion. Look at his fusion here. What's happening? He had done a posterior access, no way to restore lordosis, and he get a hypolordotic instrumentation and oops, sorry. And look at the level above. This patient had to compensate, and he dislocated the level above. So I would say in this case, if we have done an OLIF first, percutaneous second, we might not have this problem. In my hand, when like this patient, if he had a low pelvic incidence, I go for TLIF, and of course, to go for TLIF, I do my pre-op planning here. You can see this patient had a pelvic incidence of 54. He's having strong retroversion, of course, but I don't need too much of lordosis restoration, so I went for TLIF. This is my percutaneous screws here, the distractor in place, opening the distractor, bringing the rods here, and then realigning posteriorly, taking out the distractor and placing the cage. And it works for a low pelvic incidence. I have done the same on this patient who had 94 degrees of pelvic incidence. And look at my results, same technology, same surgeon, but I get a hypolordotic because this patient had 47 degrees of L4S1 instead 56 degrees needed. And patient start to have a junctional problem at the level above.
Richard, can you wrap up pretty soon here?
Yeah, I will conclude because it's mainly as a take-home message. Let me. I have a problem with my mouse. Okay, as a take-home message, you understand why OLIF is needed. It's needed because we need more lordosis than in a TLIF procedure. Okay, so I can conclude it verbally. I think it's a safe procedure. It's easy to master. It's as far as you know all the anatomical considerations, and we should be aware that hypolordosis, and I think that everybody knows that hypolordosis generate adjacent disc disease. So the OLIF is something that has to be in your armamentarium for patient who had who needs lordosis because they have a large pelvic incidence. Thank you.
Thank you very much, Richard. That was a great walkthrough, pelvic parameters and an understanding of indications for the variety of techniques, particularly OLIF. Well done. Our next speaker is Mike Steinmetz. He is the chairman of neurosurgery at the University of New Mexico. He replaced me in that position. He is all things to all people. He is a wonderful. He was one of the first residents that I selected at the University of New Mexico prior to coming to Cleveland. He has one problem right now, though, and that he cannot unmute.
I think I'm good now. They just,
okay.
I'm good.
Okay.
Yep.
So Mike is going to, we're now on time, and Mike is going to talk to us about MIS, lumbar decompression and fusion surgery using the cortical trajectory pedicle screw technique.
Thanks, Ed. And I guess your comment of now we're back on time means I cannot go over time. So I will get started here. So I'm going to talk about another procedure in the minimal access armamentarium, which is a midlift using cortical trajectory screws. And just like Richard Asker said, this is not a procedure for everything that's out there, but is good for, I think, very specific pathologies. We all know the benefit of minimally invasive surgery. I'm not going to, beat this slide up, but the whole goal is to reduce our access trauma or trauma due to access, but still have the same efficient, effective surgery. We've seen, and we'll hear more during this presentation about our experience in the lumbar spine largely, where there are now a number of minimally invasive techniques that are out there. MIS TLIF may be one of the most common minimally invasive lumbar decompression and fusions done. It does result in less tissue damage, but there's still issues related to working through a small tubular retractor to do surgery. I think one of the biggest issues is inadequate decompression working through a tube, especially on the contralateral side with significant bilateral lateral recess stenosis. It can result in increased operative time, especially early on in one's experience compared to what you could do open. And I think it just, as Richard Asker just said, there are issues working through a small tube with regards to cages. We often have inadequate fit of a cage. We may have, so we put in too small of a cage and it doesn't fit right. You try a big cage and you can injure the nerve root. And I think the other last issue about MIS TLIF is there has not been as much acceptance among non-MIS surgeons to work from a standard open and then move all the way through a tube. So there's been less acceptance amongst those surgeons. But as we know, we have continued to evolve. We're going to hear about a significant degree of evolution in minimally invasive surgery today. And I want to talk about the evolution into the midlift. This is a midline lumbar decompression fusion. It is a continued evolution of our minimal access surgery. So I would say this surgery is more minimal access than minimally invasive, meaning it's not working through a small tubular retractor, yet it's working through a very small midline approach. And it does utilize and depend on these newer cortical trajectory pedicle screws. But just like Richard Asker said with OLIF, again, we keep calling these things new, but they have been around for a while. Now, I would say list this as a tweener procedure. And I don't know if this makes sense internationally, but it's a procedure that I would say utilizes the advantages of an MIS tubular decompression fusion as well as a traditional open. It sits right in the middle or in between, and hence why I call it a tweener procedure. The benefit with this procedure, again, it's minimal access. You can do this through a very small incision. As a surgeon who does open procedures, it's very comfortable. It's a standard midline approach. Every surgeon should be comfortable with this. The screw trajectory and placement is different than traditional pedicle screws, but I will tell you it is easier than traditional pedicle screws, especially with image guidance. They're very quick, they're very easy, and there is some data to suggest that these screws perform better in osteoporotic spine because you're putting them in dense cortical bone as opposed to trabecular bone in a standard open traditional pedicle screw. So for the procedure, again, it's a midline incision, somewhere around 2.5 centimeters is all you really need. I usually put a needle in the skin, as you see here, and take a quick x-ray to determine where I want to put the incision. It is imperative, like all of our MIS surgeries, we're putting the incision right over our pathology. And the exposure is different. So if this is the exposure for a traditional open TLIF, for example, we want to expose from the end of the transverse process to the end of the transverse process. With a midlift, I really just need to expose from the top of the facet to the top of the facet, okay? So it's a very minimal exposure, just as you would, I think, for a traditional open laminectomy. There are a number of retractors that are out there on the market right now. Here's just an example of one that sit over top of the facet joint that allow you to have a very small access, but be able to do the inner body fusion. And this is just the exposure, all that you need to do this one level fusion. It's a very small incision. The retractors are in place. Because the screws aim laterally, you don't need much more to this. And here's just a picture with actually the reference array attached in a drill guide. So you don't need much more than that even to put screws in using image guidance. So for this exposure, once you expose, You really want to see the lamina, know where the facet joint is, know where the pars interarticularis is. We want to put our screws in first. You can do this under fluoroscopy. I'll show some images for that. I use image guidance, which I think makes it a lot easier. So the key part is, where do I put my screws? So it's essentially, the starting point is essentially at the midpoint of the pars interarticularis. And you can define that by finding the superior lateral edge of the pars interarticularis and move approximately 3 to 5 millimeters medial. There's often a small bony ridge there that allows one to put the screw in. Some pearls for this. I do prepare my screw paths before the laminectomy. I put the screw, or I drill the hole, I tap it, because the screws are medial. They'll get in the way of your decompression. So I essentially put the holes in first, but not the screws. You want to be careful not to create too large of an entrance hole. Remember, the screw relies on the purchase in the cortical bone and even the entry cortical bone of the pars. So don't create a large hole in the bone where you're going to put this. Once we have our starting point, we're essentially going to aim about 10 to 15 degrees lateral, bisect the pedicle, and head up into the lateral dense cortical bone. And here we can see our starting holes on fluoroscopy. So some pearls here is, we already picked our starting point on an AP image. And really the starting point is, if you're right in the mid pars on fluoro, you essentially want to be right at the level, the inferior level of the transverse process. That's the starting point on fluoro. At the upper instrumented vertebrae, you can actually start a little bit lower to try to miss that upper facet joint. And then you're going to aim 10 to 15 degrees lateral. And I will tell you that for most patients, that trajectory is, if you take your drill at the starting point, lean it up against the spinous process and drill, that is almost always the correct mediolateral trajectory for the cortical trajectory screw. And then on lateral fluoro, you want to aim up towards the upper end plate, not violating it, but get as close as you can to that. And you want to be in about the posterior 1/4 of the vertebral body. For me, in my hands, that's almost always a 35 millimeter screw is the typical length that I'll put in there. Sometimes at L5, I'll put a 40 millimeter screw. The pearls here, we want to drill our hole. We're going to tap the hole to the same diameter and the depth of the screw. I typically put a 50 millimeter by 35 millimeter screw. So I use a 50 tap, and I tap to 35 millimeters. I'm going to do all that first, place the hemostatic agent, and then do my laminectomy. And this is what it would look like. This is the trajectory. It's an up and out trajectory. And I want my screw to be sitting right in that dense cortical bone. And that's perhaps why this could behave better in osteoporotic spine. I use image guidance for this. As I mentioned, I've moved away from fluoro. I think it's much easier if you have this in your hospital to do this. Once I have my exposure, I use a drill and a drill guide and drill to 35 millimeters. Again, I do not need any bigger incision for this. This can sit right on the spinous process, right in the middle of your wound. And again, under image guidance, I can just aim up and out in that dense cortical bone, drill my hole, tap, and I can put in 4 holes for screws, probably in less than 5 minutes through that small incision. Here's just showing the proper trajectory using image guidance to put the screws in. Once I've drilled the hole, again, I'm feeling it here with a pedicle sound. I have my tap ready to go. I'm going to tap all the way to depth. And then I'm going to perform a standard laminectomy and facetectomy, just as I would in any type of TLIF, but I'm just doing it through a much smaller incision. Once I have my decompression done, here's the dura, both facets are off. I'm going to put my contralateral screws in a rod. I can use that to help distract. Once the rod is being put in here, if I have a distractor in the disc space, I can put some extra distraction on the screws plus the disc space to open up the disc space. And once that's open, then I can take my cage and then place the cage into the inner body space here, and then place my contralateral screws and then place compression. And this is what your screw should look like, aiming up and out and aiming up towards the upper end plates in the lateral view. The biomechanics of these screws have been studied fairly extensively. Here's a study out of Neil Crawford, which essentially, in summary here, these screws behaved almost the same as traditional pedicle screws in this cadaveric specimen. So they are sound biomechanically. There now have been a number of clinical studies out there. I just chose 2. This is a study of 39 patients. It was comparative, 39 pedicle screw, 40 cortical screws. When they looked at fusion rates at 6 and 12 months, no difference, really no difference in outcome, VAS or ODI in 12 months. The improvement with the cortical screws was in the perioperative standpoint with operative time, incision length, et cetera. So the conclusion was a good alternative to traditional pedicle screws. Here's one additional study out to 2-year follow-up, 79 patients with screws. looking at traditional to cortical, no difference in outcome with back pain, ODI, leg pain, the SF12 as well out to 2 years. The only benefit seen here really was in the perioperative period, benefiting cortical screws, and no difference at fusion rate. So showing that these are good sound techniques in these patients. So in a standard degenerative case, maybe improved perioperative outcomes, but the failure rate, the non-union rate, no difference in equivalent long-term outcomes to traditional pedicle screws. In my hands, I largely use this for spondy and stenosis. Again, but I want to get a good central decompression, grade 1 or grade 2. If it's highly mobile, I'd probably use a traditional TLIF. And as I showed in that image guidance, you can use it in revisions. And here's just my last couple slides. Just here's a patient with a grade 1 spondy and stenosis, fairly high ODI, fairly significant back pain. This is neurogenic claudication. Here's a patient I treated with a midliff operation. And here's the patient out at 1 year fused, significant improvement in the ODI and leg pain. Thank you very much for your attention.
Thank you, Mike. That was great. Very instructive. I think in view of our time schedule here, we should move on. Yes. Our next speaker is Abdel Fattah Obad Saud. He is going to address minimally invasive sacral and sacroiliac fixation. Obad is a prior president of this society, has been the chair of orthopedic surgery at Ain Shams University in Cairo, has been the has been the dean there, and now is second in command at the entire institution as vice president for education and student affairs, in charge of 100,000 students. He again is going to address minimally invasive sacral and sacroiliac fixation. Take it away, Obad.
Thank you, sir. Can you hear me well?
Yes.
Okay. It's an honor for me to be introduced by my mentor. So you are the mentor of a lot of people, but you have a very special place in our hearts. I will talk today about the minimally invasive fixation of sacral fractures. Sacral fractures can be classified according to Dennis or Denis into 3 zones. Zone 1, where the fracture involves the sacral ala, lateral to the neuroforaminae. Zone 2 is the transforaminal longitudinal fractures, and Zone 3 is medial to the sacral foraminae, so it passes through the spinal canal. And because this Zone 3 is dangerous, it's passing through the spinal canal. It is subclassified into 4 other types according to the fragmentation of the affected segment and the displacement as well. Especially that most of these fractures are having a transverse limb, making them H or U-shaped in most of the instances. This is another important classification that is devised for transforaminal sacral fractures that are very common. If we talk about sacral fractures, they are either completely lateral to the lumbopelvic articulation or passing partially medial to that articulation, or completely going through this articulation. The type 2 and type 3 are having some kind of lumbopelvic dissociation, especially if it is bilateral. And this is important in management, as I'm going to talk about in a few minutes. The other consideration dealing with sacral fractures is the soft tissue compromise. Most of these patients are having skin that and soft tissue that is affected like that. It's high energy trauma. Most of the skin is degloved and having subcutaneous hematoma. We have to put this in consideration, and this puts a very special emphasis on the use of minimally invasive methods of fixation around this area. The indications of surgical treatment of sacral fractures are usually expanding retroperitoneal hematoma, and usually dealing with that fracture is a life-saving thing, because fixation of those fractures would cause tamponade of the expanding retroperitoneal hematoma, and it saves patients' life. more than 1 centimeter displacement, or if there is displacement or persistent pain during conservative management. Soft tissue compromise is always there, and it's an indication for fixation, because the more stability of the fracture you get, the more chance for the soft tissue to heal. Also, neurological compromise, which is usually a bladder or bowel disturbance, L5 and sacral motor weakness is always there, or sometimes there. And surgery comprises of both decompression and stabilization. And to talk about decompression, it seems that on long term, there's no big difference on the results of direct or indirect decompression. So my special bias is to do direct decompression in incomplete neurology to give the best chance for this patient to recover, and in type 1 and type 3. And for type 2, which is the transforaminal, I tend to do indirect methods of decompression in the form of good reduction of the fracture. And then for stabilization, there are 2 biomechanical concepts that has to be put in mind for everyone who's going to try fixing a fracture around this area. The lumbosacral pivot point, McCord point, described in 1992, it's the axis of flexion and extension at the lumbosacral junction, lies in the back of L5S1 disc. And for constructs that cross the lumbosacral junction, only those devices that pass at least partially ventral to this point provide a significant biomechanical advantage regarding the rigidity of fixation. This is the point. And although this McCord point is devised for lumbopelvic fixation mostly, but during our work that I'm going to talk about in a few minutes, we felt that it applies also to fixation of the sacrum and the sacroiliac dislocations. As the more you go anterior in trying to fix around this area, the more you embrace the whole pelvis, both hemipelvis, and maybe these are the sacral bars that the orthopedic surgeons are aware of. They were used years ago and they failed. And it seems now that this happened because they passed completely behind the McCord point. The other consideration is the fixation zones, the blue area, which is the S1 vertebral body and the cephalad margins of the sacral ala, and also the both iliac bones are zone 1 and 3 of fixation, and these are strong areas for fixation, but try to avoid the green area, which is the inferior margin of sacral ala, S2, and the area till the tip of the coccyx, because it's least effective, poor bone stock with anatomical constraints. So the first method of minimally invasive fixation of those sacral fractures is the iliosacral screw fixation. It's actually a sacral screw, but it passes first through the both cortices of the part of the iliac bone, which is buttressing the sacrum from behind, then passing in this void. Then it is like a medially directed sacral screw. The problem with this screw is that it's very good for the patient, very bad for the surgeon. A lot of image intensification unless you have a navigation system. The other problem is that you cannot place it properly unless you have a perfect reduction of the fracture, which is not that very easy. Another way is to try to use iliac screws in the set of lumbopelvic fixation. This is especially important if we have type 2 and type 3 of Isler classification, as I just mentioned. And it's like that. So it's not that very much minimally invasive, because you can put these screws percutaneous, also the iliac screw percutaneous, as I'm going to describe now, but the connection is not that easy, minimally invasive. The problem with lumbopelvic fixation, you cannot use it always. It's a restraint to the lumbar, that's the weight movement. Might cause early spondylosis, adjacent segment degeneration, especially because keeping lordosis with those devices is very difficult. So we will keep them to its indications. Traditionally used other method, which were methods that were traditionally used for this kind of fixation, is the plate fixation. The problem with the plate is not only that it's not easy to be put in a minimally invasive way in a jeopardized skin, but the effective screws that are one screw here, one screw on the other side, that can be passed as pelvic iliac screws. And also you can put these screws in that direction to be like sacral screws passing into the ala of the sacrum and maybe the first sacral segment, but it's not easy to be put minimally invasive as well. Again, I'm coming back to the sacral bars because I said that they failed because they are completely posterior to the pivot point. The work that I've done beginning from 2009 and published in 2011 is that to change these sacral bars into effective ones by attaching them to iliac screws. So now the whole construct is just embracing the pelvis and buttressing the sacral fractures. This is the first two cases that were published in World Spinal Column Journal in 2011. This is the idea: iliac screws connected, or two iliac screws on each side connected. These were the very first cases where our incisions were big. Now it's just 1 centimeter incision for 2 screws. And in this very first case, it was open book. So I used a small symphysial plate and then placed this device from the back. Since it's very minimally invasive and use a very small screw, even in those open book fractures, I can use a belt like this one, flip the patient after reduction, and use very small incisions to put 2 screws on each side with no need for symphysial plate. And this is an example of such a case. It can be used also with vertical shear. And this is an example of very good reduction where the intact hemipelvis brings the mobile hemipelvis in a very good reduction, like cases of spondylolisthesis. And this is even sacroiliac dislocation open book with the use of belt as well. And this is the kind of reduction that we were able to achieve. This is not a very minimally invasive one. It's a fragmented fracture of the sacrum that needed direct decompression. And with lumbopelvic and ilioilial fixation, patient recovered neurological deficit. This was studied biomechanically in the United States in the University of Toledo, myself, Lisa Ferrara, and Andy Wakefield. And it's even stronger than intact specimen. And we showed this in 2015 in San Diego in ISASS meeting. And then we were honored by publishing in 2018 in the World Neurosurgery our longer term follow-up of our cases, 3 years follow-up, 66% excellent final result, Wellman score, 18% good final results, and 16% fair results. The only problem with the iliac screws is the prominence of the iliac screws at the iliac crest. So instead of using iliac screws, we can use S2 Ehler iliac screws that can help also to be joystick to reduce displaced fractures like this one, and then use them for fixation. Also, if you use them with lumbopelvic fixation, it's more in alignment with the other screws at the lumbar area. So we are using it more and more now. The other indication that we are using this ilioilial fixation for is for fusion of arthritic sacroiliac joints. These are the devices, one of the devices that is used now for minimally invasive fusion of the sacroiliac joint. It needs navigation or image intensification, but our device can work without all this. Just fixing and compressing, it worked. Fixing, compressing, and do some decortication and grafting of the sacroiliac joint in a mini open way, or just compressing it and using bone marrow aspirate as a adjunct for fusion. And we can use it also with S2 Ehler iliac screws. It works very well, and we're about to publish long-term results. Thank you very much.
Okay, thank you. That was great. Do we have any questions? We don't really have any time right now. There are some questions on the chat room that maybe you could go to, Mehmet.
Okay.
I mean, Obad, to address. Our next speaker is Joachim Ortel. He is the chair of University Hospital in Saarland in Germany. Joachim is a delightful person. He brightens up every room he enters. He is knowledgeable, and when he speaks, everybody listens. So he is going to address us today with discectomy, transforaminal or interlaminar approaches. Joachim.
Well, thank you, Ed, for the introduction. It's a pleasure for me to present this, and this is a particular pleasure because I think this is a topic which is particularly interesting for Asians and like Korean colleagues, because the technique of transfemoral approaches is much more popular there than in some parts of Europe, at least. So I will focus on this transfemoral versus interlaminar. And this is my disclosure. I don't want to go into too much detail. This is where I'm from. So very small city in the southwest of Germany. Here I work, and it's 1 hour from Frankfurt, Strasbourg, Luxembourg. And this is a picture of the department. Theoretical advantages of spine endoscopy. Well, we have improved visual quality directly at the target. We have a possibility of a look around the corner. Reduce collateral damage because we reduce the size of the approach, and ideally we have new surgical techniques and options just because we use an endoscopic technique. This is true in neurosurgery for the endoscopic third ventriculostomy, and to some degree in spine surgery and spine endoscopy for the transfemoral approach. When we focus on endoscopic spine surgery, we almost always focus on degenerative indications. This is just a vast majority of indications. In contrast to other endoscopic indications, we have no preformed cavities, so we have to create space to bring in the camera and the endoscopic system. Also, we have very good results with microsurgery. We need sufficient decompression of neural structures, and I think this is the key point I will discuss later when we at least recommend transfemoral and when we do interlaminar approaches. And then in some cases, we have to treat deformity and instability in the same setting. We have theoretical advantages like minimal muscular trauma. We might have smaller scarring at the dura because we have a mini opening and very high magnification, so we can limit the size of the approach. And there's a significant patient demand, superior cosmetic results, and less post-op pain and faster recovery. Well, there's a vivid controversial discussion. One is whether you use a microscope or you use an endoscope. Then when you go into the endoscopic world, then you see tube-based versus so-called full endoscopic, or transfemoral versus interlaminar. What is the status of evidence? Well, I will not go too much into detail. Microscope versus endoscope. We have now a lot of studies which show that we can achieve the same recurrence rate and same complication rate with the endoscope than with the microscope. But the immediate post-operative pain is less and faster recovery the smaller the approach is. We have superior cosmetic results, but we have no evidence for superior long-term results. Well, this is pretty clear, the evidence we have now. When we look how to categorize the endoscopic procedures, then we base them on tube-based endoscopic assisted. I think endoscopic assisted is not a good term, but we use tube-based systems where we have the space of the tube to maneuver with our bimanual technique. So basically it's a small microsurgical bimanual technique, or we have percutaneous full endoscopic procedures where we just have one instrument going in and going out. There's a vivid discussion which is better and which is more superior, but I will not go into detail. What is my topic today is transfemoral versus interlaminar. So whether we come interlaminar to approach the lesion and to achieve the goal of surgery, or we come through a transfemoral approach. For the transfemoral approach, there are various techniques available, but we need a shear full endoscope. That means we need an endoscope with integrated working channel, irrigation suction channel, and an optical lens. So these endoscopes are very small. An ideal indication for these procedures are interfemoral or extrafemoral disc prolapses. In this case, we have an L4-5 interfemoral disc prolapse here on the upper right, lower right. I think this is an ideal indication for such a procedure. And when you look at this video, I will forward a little bit for time purposes. You just go in and you use this under water, just irrigation. You go in and take out this big disc prolapse. This is really literally a very minimally invasive 5 minutes procedure if this is the indication is good. And this is what you can take out with this transfemoral technique. Skin incisions more or less 5 millimeters in size, so very small, very rapid, fast recovery. When we compare this with the interlaminar approach, at least in tube-based or endoscopic techniques, we go transmuscular. We do a limit opening, and this is, in my opinion, a very good indication for such a procedure. This is a caudally migrated disc, medial lateral disc, and you see here, when you look at this, that this is the nerve root S1, and this is the thecal sac. So this will be difficult to decompress the nerve root and take out the disc. And this is the example for this, just for purposes here, to rush up a little bit. We have here now the nerve root here. This is medial, this is lateral cranial caudal. You see here, there's the thecal sac, and right in the axilla, you see this disc prolapse. And ideally, you just take it out with one single huge step. Where is it? I think it's 228, I remember. Should be here now. Yeah, that's coming. You see the opening of the spinal canal. All this is preserved ligaments. So this is a suction device of 3 millimeter in size. So the opening of the spinal canal might be 3 by 4 or 5 millimeters in size. Of course, these are ideal indications for interlaminar or transfemoral approach. So when we look at the literature, there's no large randomized prospective trial available. We have meta-analysis, including transfemoral, where there's microscopic interlaminar approaches. And we see that with the transfemoral, they have a very fast recovery. But to see the advantages, the smaller the approaches, the more significant the effect is, the shorter hospital stay and less pain with transfemoral techniques than with microscopic interlaminar. But there are different techniques, and the experience is required to apply these techniques. So I think there are very various discussions about what to do with the lumbar stenosis, what to do with lesions on the contralateral side. And for example, this lesion, we pretend to have a contralateral lesion in this side. We would not approach this with a transfemoral. If you have a migrated disc or something right behind the vertebral body, we will not do it with the transfemoral. On the other hand, if you have an extrafemoral disc prolapse, we will not do this with an interlaminar approach, because then we have to sacrifice the facet joint and to reach the surgical goal. So how to select the approach? And I think this is would be a nice topic for next year, World Spine in Korea, because Korea, I think they have a huge group of spine surgeons who favor the transfemoral approach over the interlaminar. How to select the approach? Surgeons have to know the advantages and disadvantages of both approaches. I think this is key step. Ideally, the surgeon is experienced in both techniques. This is not that easy to gain because there are not that many doing both approaches. And then we have to select the individual of pathophysiology of the patient. So what is the pathology? Is it disc, is it bony stenosis, or even tumor? Do we want to treat the instability with this? So then all this will bring us more to a midline approach. What is the localization of the lesion? Is it extrafemoral, interfemoral, or is it in the spinal canal? Is it bilateral or behind the vertebral body? And then what is the history of the disease? Is there scarring to be expected, earlier surgery? Or for example, do we have a bleeding problem we can anticipate, like in a patient with some hemostatic disorder? All these will influence the decision-making, whether transfemoral or this interlaminar. And then another important thing is you just do biopsy. You want to do a pus evacuation, like in a discitis case, or we aim for complete resection of a tumor, or even decompression and neurolysis of nerve fascicles. So after decision on the ideal treatment, we have to come back and ask ourselves, are we able to perform this procedure? And based on these techniques, I think in any extra and intraforaminal disc, like disc probes, or in any interdiscal disorder, like in a tumor, you want to do a biopsy, like in a discitis, you want to evacuate the pus, decompress, and gain microbiology findings. Soft lesions are in soft lesions, the transforaminal approach is favored. This is what we recommend, at least in our hands in our state. In central and bilateral lesions, and if meticulous preparation is needed, if a lot of bone work is required, or difficult surgery is anticipated, I think there's no role for the transforaminal approach. Then we should come from the interlaminar traditional approach, which gives us very superior results. Well, thank you for listening, and invite you for an endoscopy week whenever you are interested. Thank you so much.
Welcome. That was great. A great decision analysis portrayal. We're a little bit behind. I'm going to transfer the moderator duties to Mehmet Zileli, past president of this organization and from Izmir, Turkey.
Thank you, Ed. It was great honor for me to be a part of this organization. It's really, I have to congratulate all the organizers. Now I want to introduce Dr. Hyun Sung Kim from Nanuri Hospital, Seoul, Korea. He is a very well-known endoscopic spine surgeon, and he will tell us the advanced endoscopic spinal decompression techniques. Okay.
Thank you so much, Professor Mehmet Zileli. It is great pleasure and great honor to give a lecture in virtual world spine. This time, everyone, good morning, good afternoon, good evening, everybody. And I'm Hyun Sung Kim from Nanuri Hospital from South Korea. This time, my lecture is the advances in endoscopic spinal decompression. And this is my curriculum vitae disclosure. Yes, recently people's mean life increased so much because of that. Spinal disease also moved from disc pathology to stenosis pathology. In spite of them, so much people of the degenerative spinal disease with the increased mean life, because of that they need more minimized option of the treatment, especially like minimal invasive spine surgery and endoscopic spine surgery. Fortunately, endoscopic spine surgery developed during last 10 years, developed so much because of that. Before time, we discussed many discectomy treatment under the endoscopically, but nowadays it moved to the generation from the discectomy to stenosis without instability generation. Because of that, nowadays we can manage the more sufficiently of the endoscopic by the endoscopically to the degenerative spinal stenosis and the degenerative spinal disease. For example, this is my paper we publish, and in this paper you can see with the development of the generation of the endoscopic skills. First generation, the discectomy generation, and second generation is the discectomy and decompression generation, and nowadays the generation of the discectomy decompression and fusion endoscopic fusion generation. And then now we can manage the more than 95% of the degenerative spinal disease patient with under the endoscopically without the open surgery, and also can take a good to excellent clinical result. For example, we can nowadays we can measure easily like this patient. This patient is 78-year-old female patient with severe stenosis with combined with spondylolisthesis. In these cases, you can see that some mild instability, not severe instability. How treatment will you choose for this patient? Yes. Anyway, the rationale of the endoscopic spine surgery is not only limited to the minimized option of the treatment, but also compared to the, because of that, the tubular decompression also already done the minimized option of the treatment, but endoscopic decompression can give more 3 different special characteristics, like it has a more mobile and angled characteristics, and because of that, it can approach more easily to the detailed point. And also the view of the operation is more deeper. Because of that, we can manage the more detailed works under the more obscured area. And also this all process can performed under the fluid-based operation, and can we take a more clear operation field in spite of the most deepest point of the obscured field area of the operation. Because of that, this MR image taken 1 day after operation of the endoscopic decompression, then we can see the endoscopic decompression rationale is not only the minimized option of the treatment, but also there is sufficient neural decompression and preserve the functional segments, and also minimizing the paraspinal muscle damage and the less neural tract. And also finally, we can increase the normal life activity. And the science base of this endoscopic decompression already published so many authors. And also the indication previously only limited some of cases, some mild spinal stenosis, and also some central, some lateral recess cases. But nowadays, with the development of the endoscopic techniques, in so many textbooks, they talking that the indication is near all kind of the spinal stenosis, in spite of the central stenosis, lateral recess stenosis, and foraminal stenosis, and far out syndrome can possible. But also there have some contraindication of like such as more than grade 2 spondylolisthesis and remarkable instability, and like a neurologic damage state. Anyway, nowadays the endoscopic decompression can possible approach, can divide the 2 approaches. One is the under the top technique, one is the over the top technique. But over the top technique means that the outside in approach. It's like that. Anyway, before time, initially we came doing the inside out and under the top approach. But if we hope to expansion of the indication of for degenerative spinal stenosis like this very severe cases, or thorax or cervical cases, hope to can possible under the endoscopically, I hope to recommend the outside in over the top technique. Then we can take a good to excellent result in spite of the so severe spinal stenosis cases. And also there needed some technical consideration of this outside in over the top technique, like it basic is the laminar drilling. Because of that, we should knowing these anatomy structures. And also if we hope to approach more deepest point, because of that the working channel sometimes bigger, but because of that we hope to approach more deepest point, we can change it small working channel using the switching technique like this. And the drilling is the very important point of this outside in approach of the over the top technique of endoscopic decompression, like this. And also we should keep in mind this, because of that the purpose of the endoscopic decompression is the minimized option and to preserve the facet joint. Because of that, to preserve the facet joint, we should keep in mind that the anatomy keep the medial border of the pedicle or medial upper tip of the supracortical process. Then we can preserve the facet joint sufficiently. And also one more important anatomical structure is that if we hope to over the contralateral side safely, we should know that these anatomical structures of the spinolaminar angle cranial to caudal. Unfortunately, this anatomy can see like this V shape under the endoscope view. Then anyway, we should checking these 3 viewpoints to overcome the contralateral side safely, like this. Sorry. But anyway, endoscopic spine surgery also have several complications. Among them, the most serious complication will be the dural tear. Fortunately, this dural tear can managed by the patch blocking dural repair technique. This technique already published in World Neurosurgery, and it is not difficult to manage under the endoscopically, because you should try this. You can see this cases 6 months follow-up, the patient have no problem. I will show finally some of cases. You can see this case is 80-year-old female patient with very severe cases of spinal stenosis. It can possible under the endoscopically. Also, this case is central stenosis, foraminal stenosis, and contralateral stenosis. In this case, it also can possible central decompression and possible to contralateral approach using the switching. After switching more small working channel, then we can solve this pathology by one step. And also you can see that this thoracic OLF cases also can possible endoscopic decompression. 1 year MRI follow-up see the well decompression, well sustained stability. And also some of cases of cervical stenosis can solved by the endoscopic decompression like this. Yes, finally, I will give the answer of the first question. This patient is a 78-year-old patient, female patient with severe spinal stenosis L3-4 and L4-5 instability, spondylolisthesis. I choose the endoscopic decompression for this patient and postoperative MRI, and 6 months follow-up X-ray cannot see more aggravation of the instability. Also, stenosis is still not well decompression state. In conclusion, take-home message. The indication of endoscopic decompression, stenosis decompression now expands the all kind of endoscopic spinal stenosis. And also there have some technical tips to give the over or outside in over the type endoscopic decompression, such as spinolaminar angle, sublaminar drilling, mobilization of the endoscope, and the contralateral approach. And anyway, after developing this endoscope decompression, nowadays we can possibly apply the endoscope lumbar interval fusion surgery, and so many widening of the endoscope indication of the endoscopic spinal surgery. Thank you for your kind attention.
Thank you, Hyun Sung Kim. It was a great overview of the endoscopic surgery. We are not having much time to ask questions, but if anyone wants to ask questions, they must send a message to virtualworldspine@gmail.com. So through the email, we will answer you, and then we will publish them. Our next speaker will be Dr. Vasilis Likomitros. He's an orthopedic spine surgeon from Greece, and he's doing many deformity surgeries. Is Vasilis here?
Yes.
Can you please, share your screen?
I like to comment here. Vasilis is also a world champion, 1986, I believe, world champion, was on the world champion rowing team, and a 1988 Olympian.
Yeah, in Seoul
Thank you very much. Thank you very much for the invitation to talk, and thank you very much for all of you, Ed, Mehmet, for keeping me in the wider company of this excellent society.
Thank you for being with us.
I'm very, very proud to be here and present our work here in Greece. If we may start.
Please share your screen, the green button at the downward.
Sorry. Okay. All right.
Good.
Okay. So.
Good.
The question was why you should start minimally access for the deformity cases. And of course, we heard before about the privileges for blood loss and less comorbidities. But the more we go, the more we learn that all these difficulties about that. In this advertisement from a big company, it says down here, less OR time, which is not actually true, but it's shorter hospital stay and saving on blood loss and cell saver, it's true. It all started, of course, with deformities, spondylolisthesis, kyphosis and scoliosis, and the TLIF cases that we did. But we went all the way to have our cases of laparoscopic insertion of large A-leaf cages in order to mainly correct not only the spondyloptosis, but as we can see here, to have a 50-degree correction of the kyphosis deformity. And then we started to work on the adult deformity cases, where we saw by the literature that we can correct the sagittal balance, which was a new thing back in 2005, 2010. And we managed to do cases like that with large osteophytes and kyphosis and scoliosis, and corrected with T-leaves, balloon insertion and kyphoplasty, and do these hybrid cases in order to correct the deformity. And then the next logical step was to apply minimal invasive surgical techniques to the treatment of adolescent idiopathic scoliosis, and of course start with the mild curves. There we saw that the same correction, less bleeding and less pain, and quicker return to school was possible with these operations. But in contrast to adult degenerative scoliosis, the curves in adult idiopathic cases was larger curves, 50 or more levels to instrument, the deformity to be in the 3 planes, and the vertebral rotation to be one of the main parts of the deformity. But we managed to have the similar deformity correction and adequate fusion with the osteotomies of the facets. And of course, the problem was the learning curve and the instrumentation that was not yet adapted to do the derotation of the scoliotic curves. Of course, we saw results with significantly lower transfusion rate, shorter fusion length, which was very important, and less pedicles to be fixated. The skin was a big problem, especially for the adolescent girls. The standard stab incision for placement of minimally invasive screws could not be utilized in adolescent patients, as 14 or 26 stab incisions in the back can be quite disconcerting for the young patients. So we started to plan our cases and do 2, 3 or 4 midline incisions and pulling the skins right or left in order to do the insertion of the screws. The placement of a lot of pedicle screws, of course, increased the radiation exposure for both the patient and the surgeon, and especially in the double major curves, passing a contour rod. That is, it was a big challenge and a great difficulty. Of course, we should have adequate fusion with the osteotomies of the facet joints because BMP is off-label for the young patients. We came to the era of O-arm and navigation, which the big solution for that was that we could reduce the radiation exposure, and we could also be very accurate with the placement of the screws. In this presentation, we show the comparison of radiographic parameters, which relieve an obvious difference between the two, no obvious difference between the two groups immediately after surgery and at the final follow-up, significantly less EBL and longer operation times, this adding also the O-arm, and the same high accuracy in both groups. The same high accuracy with or without the O-arm means a lot of experience, of course, but means also that it's possible to do it in a not so advanced operating theater. Of course, we should adapt our instrumentation in order to do these very complicated maneuvers for the reduction. And it is especially true when attempting to restore normal thoracic kyphosis. This is very difficult as a contour rod often sticks above the screw heads and you need to do certain specific manipulation. But instrumentation slowly adapted to that problem. Overall complication rates in the MIS and hybrid surgery groups were similar, and significantly fewer neurological and minor complications we saw in these MIS cases. Reoperation rates in both groups were similar also. And we come to the neuromuscular cases, which are especially the pediatric ones, which are the most difficult. And we show this paper from France, Paris, where they adapted their instrumentation and succeeded to have an improvement in the comp angle of 61 degrees. And pelvic obliquity improved in 83% with less complication and infection. But they made their own adaptations for the iliac screw fixation and for sliding rods, as you can see here in this area of the instrumentation. So they had the progressive correction of the deformity, and they had pelvic fixation for the iliosacral screws in these osteoporotic pediatric bones. And here are the excellent results. Now, in our case, we have an adult neuromuscular case with Parkinson's kyphoscoliosis, a combined case, a 78-year-old female. The one critical thing is that the 3 medications that she received had a good control of her Parkinson's disease. She had progressive kyphosis, which was the main thing for her the last 2 years, and she had low back pain and bilateral trochanteric pain. But we should not miss the trochanteric pain with sciatica. There was no sciatica. And you see, the main scoliosis is at the lumbar spine with fusion and osteophytes in the lumbar discs, and in the thoracolumbar, which means that the muscles could not really hold the thoracic cage, was the main part of the kyphosis. But you can see on the table, if you properly examine the patient before the operation, you can see that she slowly adapts and she gets a good shape. You adapt the operating table to where you want to work. And this is a K2M instrumentation, which help you to push the rod down to the head of the screws for the kyphosis. And in order to adapt for the L5S1, you can see here we put a T-leaf cage in order to have a distal good fusion. We did multiple osteotomies of all the facets of the lumbar area in order to correct the scoliosis by cutting completely between the two screws the facet joint, so it gets a lot of relaxation by cutting here, actually exactly at this point. And then we put two hooks and we left a little bit the rods for the future, and multiple screws for the osteoporotic bones. And you see this very nice correction, which needs actually more lordosis here, since this point comes a little bit in front of the sacrum, but you can see that it's a huge correction for before, and the patient is walking again in a much better posture, and a lot of work has to happen by the physiotherapist with the iliopsoas muscle, which tilts the pelvis and the back muscles. So although there are multiple perceived benefits, long-term data is needed before it can be recommended, the MIS adults, the MIS scoliosis, for routine use. Thank you very much.
Dear Vasilis, it was a great presentation, really. We thank you for this nice presentation, and we must keep the other speakers. The questions must come to our email.
Okay.
The other speaker is Dr. Nikolai Peev. He's working in Belfast, North Ireland, in the Royal Victoria Hospital. He's originally from Bulgaria, and he has moved there for a long period ago. Can you please unshare your okay, Nicola?
Yeah, I can share my my screen now, I think.
Yeah.
Thank you so much, Mehmet, for the presentation. Great pleasure being with you today, and great honor, and thank you so much for the opportunity. I'm grateful for that. So I was asked to talk about minimally invasive spinal surgery today. I'm going to try to twist it about can we make it a bit affordable, being influenced from previous presentations and having on mind that we have audience that probably doesn't have the most advanced theaters that have everything that they need to have and to do all kinds of surgeries. So as it was mentioned, I come from Belfast. This is part of the United Kingdom. This is my institution where I work now. We have a nice cadaveric facility where we organize courses. This is an interesting slide that I wanted to show you to see how the surgical technology was developing. As you can see, from somewhere mid-century, 1944, at the end of the war, the PLIF procedure was described. And then we developed minimal invasive techniques only at the end of last century and the beginning of this century. So for the last 20-25 years, we have now developed minimal invasive techniques for every kind of, nearly every kind of surgical procedures. But unless you are in US, where obviously there is a higher prevalence of well-equipped theaters, maybe this is the reason why about 3% only of the surgeries are done in a minimal invasive fashion around the world. This is company data from 2019 that I got. So speaking about minimally invasive surgery, I just want to shortly remind you the concept of surgery at all. This is a task that you have to do by reaching a target or aim that is inside tissue. So you have to split healthy tissue. You have to do the surgical procedure, and then you have to close. So with that, you inevitably destroy normal healthy tissue. So you leave footprints. That is what the minimally invasive surgery is trying to overcome. So you leave less footprints when you do your surgery. So it's a no-brainer if you consider that this is the result of most of the spinal surgeries nowadays. It's no-brainer where you want to start. Do you want to start from this or you want to start from that? So minimally invasive surgery will allow you to leave less footprints. And I want you to think about that not as a separate type of surgery, but as a concept. So the concept is leave as less footprints as you can. So if you have to define the minimally invasive surgery, this is a surgery that gives you less collateral tissue damage, measurable decrease of morbidity, faster functional recovery, and you're still able to reach the surgical goals that you would reach with the open surgery. How we do that? We preserve the muscles. We limit the width of the surgical corridor. We use normal anatomical planes, and we try not to disrupt the tendons and the attachments of the muscles. So most of you already, if you think most of you already do minimally invasive surgery. Anterior cervical surgery is a good example of that. If you think it complies with less collateral tissue damage, a measurable decrease of morbidity, faster functional recovery. If you go anterior, you do a lot of work there, and you don't disturb the muscles, and the patients are happier than if you go posteriorly. And if you think our founder, Ed Benzel, he said yesterday, presenting the minimal invasive book, that he is not really a minimal invasive surgeon, but he is. And the proof of that is that he published this paper in 2017 saying that anterior is better than posterior. And this is because anterior is minimal invasive. So muscles. Muscles are one of the most important structures that we are preserving with minimal invasive surgeries. As you can see, there is a lot of muscular layers that are wrapping your spine, and you have to take care to preserve them. And if you do that, your patients are doing better. And there is a lot of literature suggesting this now. So why we have to bother with minimal invasive? We have to do it because it's going to be good for your patient, it's going to be good for you. It will reduce the infection rates, you're going to reduce the blood loss, you're going to reduce the pain, you will use less instrumentation, it's going to be more cost effective. Patients are demanding it nowadays, and that will allow you to operate patients that would be unthinkable with the open approaches. For example, I have done a few days ago a patient which was with BMI 48, and it would be difficult to do that with open approach, but minimally invasive did well for the patient. So, of course, like any other surgery, you will have to overcome some difficulties. You have long learning curve, you have radiation exposure, you need specific equipment, and most important, you need technique. You have to have good technique, and then things are coming well. So speaking about learning curve, we are all talking about this steep learning curve. So I decided to show you that and to show you why the learning curve is steep. We have now research suggesting that if you would like to do minimally invasive, you need to do about 50 cases to reach your 90% milestone. And then you become hobbyist. If you would like to become expert, you need to probably do another 200 cases, which will take way more time than for you to reach your 90 milestone. So the last 10% will take you so much time, and that's why we say that the learning curve is steep. But being persistent, you will learn, and you will reach your 100%, and you will become experts. And you will do things which are not possible to do, and you were thinking that you are not possible to do before time. So radiation is one of the biggest pitfalls of the minimal invasive. Of course, it's best for you to have some sort of navigation that will bring the dosage low for you. But if you don't have, you are not necessary to wait. You can start with what you have. You can start with your X-ray there that you have in your department. And knowing the principles of radiation protection will help you to not be exposed to radiation so much and to protect yourself. This slide is showing you that where you stand in respect of your image intensifier will significantly reduce your dose. For example, if you're on the side of the tube, your radiation is way higher than if you're on the side of the receiver. And then you see here that if you put your tube above the patient, the dose is significantly higher than if you put the tube below the patient. So all these things you have to consider when you do your surgery. I will stop a little bit here. That paper was very, very interesting for me. It's coming from South Korea. So the authors basically did research, they did an experiment. They put a detector that was wrapped in a lead glove, and they used another detector that was not wrapped in a lead glove. So the lead glove wrapped detector was on the patient, and the patient at the detector that was not wrapped in a lead glove was away only 30 centimeters from the patient. So the detector that was on the patient wrapped in a lead glove received way more radiation than the detector was not wrapped, and it was away from the patient only 30 centimeters. So that comes to show you that even if you step only one step back, that will reduce significantly your radiation exposure. So ask your radiographer to X-ray only after you step back with one step even, and that will significantly reduce your exposure. So it is good to have modern equipment, but if you don't have, you can think out of the box and you can overcome your difficulties, and you can still apply the principles of the minimal invasive surgery. That is how I started in the beginning, where I did not have my special spinal table. This was the retractor that I started using in the beginning. This is Norman McCulloch retractor, and it serves well to develop your Wilson approach if you don't have the fancy new modern tubular minimal invasive retractors. And that gives well enough exposure for you to do all of your approaches and to do a lot of work through the minimal invasive approach. So another point that I would like to stress, minimal invasive screws. Of course, initially we'll have a period when you will take more time and more radiation to put your screws. But with time, as you can see, this is how my times and my radiation exposure developed over time. Initially, I started with way higher times and doses than lately. So perseverance will pay, and you have to continue with what you have there. So as a wrap up, I would like to tell you that the minimal invasive surgery is a philosophy, is not type of surgery. And thinking out of the box, you can start, and you have to do it because that will be good for your patients, and that will be good for you, and you can make it affordable, and you can make it happen with what you have there. Thank you.
Thank you, Nikolai. It was a great talk, really. You also use some tube-guided surgery, do you?
I use tube-guided surgery, but sometimes depends on how much I have to decompress. I might still use that McCulloch retractor that I showed you. I've just ordered longer blades, and then outside I use just one spike, and inside I use the long blade, and I can reach contralaterally and do wider decompressions without problem.
Okay, thank you a lot.
Thank you.
Now we came to the session of selected free papers. I think Dr. Nurullain Iqbal will present the people.
Yeah, sure. So the first presenter we have is Dr. Burak Eren from Turkey. They'll be presenting on the relationship between spinal pelvic parameters and recurrent lumbar disc herniation.
Dear presidents and colleagues, this presentation is about relationship between spinopelvic parameters and recurrent lumbar disc herniation. Spinopelvic parameters have been associated with lumbar degenerative disease, particularly for lumbar disc herniation. We aim to investigate preoperative spinopelvic mismatch as a risk factor for recurrent lumbar disc herniation in patients undergoing surgery for first-time lumbar disc herniation. Data of 1,453 patients in 6 years were reviewed, older than 18 years old, and who underwent surgery single-level unilateral fenestration microdiscectomy for the first time in our hospital selected. The study group comprised 88 patients who underwent surgery for recurrent lumbar disc herniation. The control group comprised 101 randomly selected patients who underwent surgery for lumbar disc herniation but not recurrence. We look all patients before first operation, demographic data and intervertebral disc height, segmental lordosis, lumbar lordosis, pelvic incidence, sacral slope, pelvic tilt, and sacral table angle. In results, mean age was 46 years old. The mean time to recurrence was 167 days. Both groups were similar with respect to age, gender, BMI, occupational activity level, and level of surgery. And all table mean intervertebral disc height was significantly lower in the recurrence group, and less lumbar lordosis and lower pelvic tilt at L3-4 level, increased sacral slope at L5-S1 level were considered risk factors for recurrence. In addition, in men, lower sacral slope and lower segmental lordosis, and in women, lower pelvic tilt were considered risk factors for recurrence. Pelvic incidence, pelvic mismatch, and sacral table angle were not related to recurrence. This study showed that preoperative intervertebral disc height, segmental lordosis, lumbar lordosis, pelvic tilt, and sacral slope in patients undergoing surgery for lumbar disc herniation patients may be at risk for recurrence. Thank you.
The next presentation we have is from Dr. Nishank Mehta from Delhi on design and implementation of enhanced recovery after the surgery protocol and elective lumbar spine fusion.
Am I audible?
Yes, you are, yeah.
Yeah, so good afternoon, everyone. Greetings from India. I'll be presenting our work on the design and implementation of an enhanced recovery after surgery protocol in elective lumbar spine fusion by posterior approach. So what is ERAS? ERAS is a departure from the traditional perioperative patient care that we are all used to, which places the healthcare provider at the center of the management. Rather, ERAS is a patient-centric approach to healthcare management, where there is a seamless integration across different stages of a patient's surgical journey and across multiple disciplines involved in patient management. Strategic evidence-based interventions are made in the preoperative, intraoperative, and postoperative stages of patient management. ERAS has been successfully validated in various surgical disciplines, but there is limited evidence to support its use in spine surgery so far. The novelty of our study was that it was the first study to explore the use of ERAS in the context of a developing country setting. Our objectives were, first, to design an evidence-based ERAS protocol for elective lumbar spine fusion, and second, to compare its results with conventional perioperative patient care. The ERAS protocol was implemented in our hospital in December 2016. All patients operated before that constituted the pre-ERAS or control group, and all patients operated after that constituted the post-ERAS or the intervention group. only adult patients undergoing 1 to 3 level elective transforaminal lumbar interbody fusion were included. The ERAS pathway components were selected on the basis of evidence in literature, the existing hospital facilities, and the prevalent local practices by a multidisciplinary team. The outcome measures were the length of hospital stay, the rate of postoperative complications, 60-day reoperation and readmission rate, and patient-reported outcome measures. Out of a total of 800 patients, 490 patients belonged to the pre-RAS group and 310 to the post-RAS group. There was no difference in baseline variables. We observed a significant reduction in the length of hospital stay in the post-RAS group, without there being any significant increase in the rate of postoperative complications or the 60-day readmission and reoperation. In addition, we also observed significantly lower VAS and ODI score at 4 weeks in the post-ERAS group, with there being no significant difference at longer follow-up. To summarize, a comprehensive 28-component ERAS protocol was successfully implemented in the setting of a public healthcare facility in a developing country. Due to time constraints, I'm not able to share the protocol in detail. The limitations of our study were the retrospective study design, a limited follow-up, recruitment of patients from a single center, and there was no measure of cost effectiveness of the protocol implementation. To conclude, ERAS implementation leads to shorter length of hospital stay and better functional outcome at early follow-up without increasing the incidence of complications or the rate of reoperation. I thank you for your attention.
Thank you.
Thank you so much. Next, we have Dr. Javier Oliveira from Mexico. He'll be presenting on endoscopic interlaminar discectomy combined with ventral epidural adenolysis. Is he there?
Yeah, I'm here. Okay. So I want to share my screen. Okay. Can you see my screen right now?
Yes, you can. Yeah.
Okay. Thank you very much. It's a great pleasure to share our research in this virtual world Spine 2020. I'm going to talk about endoscopic interlaminar discectomy combined with ventral epidural adhesiolysis for patients with disabling radicular pain. I'm Dr. Javier Quillo Olvera from Querétaro City, Mexico. As you know, the patients with chronic nerve root treatment because disherniation and disabling dysesthesia usually persisting with symptoms after discectomy. This is because the severe chronic inflammatory process can distend the epidural vessels, form tight adhesions, and fix the nerve. And this can be risky when you perform endoscopic approaches to decompress the nerve. So we conduct a report to know the intensity of remaining postoperative symptoms from patients with chronic and disabling radicular pain who underwent endoscopic interlaminar discectomy with and without percutaneous adhesiolysis. We perform first the adhesiolysis via transsacral, and then we perform the discectomy. We conduct a study from March to August 2018 in 20 patients enrolled in a prospective case-control comparative study. All patients had lumbar disherniation diagnosed by MRI with a minimum score of 8 in the VAS for leg pain during at least 4 weeks, treated conservatively. No diabetic and osteoporotic patients were eligible, and the group 1, conformed by 10 patients, underwent for the full endoscopic interlaminar discectomy only. The group 2, conforms 10 patients, underwent the same endoscopic procedure plus a steerable catheter-based adhesiolysis and analgesia in the ventral epidural space. The postoperative clinical results were measured and compared between groups. As a result, the group 2 resulted in immediately higher postoperative VAS scores compared with group 1. Only postoperative acetaminophen was required for group 2 patients. The group 1 needed more than one analgesic drug, but no opioid was required in both groups. The time to return to daily activities was slightly earlier in group 2 compared with group 1. And summarized, the endoscopic discectomy combined with ventral epidural adhesiolysis and analgesia resulted in a feasible option for patients with severe and chronic preoperative pain caused by lumbar disc herniation. Thank you very much.
Yeah, thank you for very nice study. I think we must skip the case discussion. That I guess Doc Orr is here.
Yeah. I don't, if you want to skip, that's no problem.
Good. Yeah, we will listen you. Yes, your case, Doc.
Go on, Doug. We're waiting.
I thought we were, oh, I thought we were, okay. Here we go.
You share the screen.
Yeah. Okay, here we go. All right. So again, we'll do this like we did yesterday. Hang on, let me just. Okay, we'll do this like we did yesterday. If Mehmet, if you could read some of the things that come up on the chat, and if the faculty could, you know, that some of the faculty could share, we'll just sort of do a little bit of a discussion. And what I've done again is I've picked one case and possibly a second if we get through the first. But you know, rather than as most case presentations are done, where it's something weird and bizarre that you'll never actually see, I always like to do the cases that we commonly see, and there's a lot of variation in how they're treated, so that we can get an idea of what people think. So here's our first case. This is a 58-year-old male. He has a 1-year history of activity-related axial back pain. It's about 60% back pain, and bilateral it's 40% back pain and bilateral leg pain. 60% leg pain, 40% back pain. His walking tolerance is currently limited to about 200 meters due to the leg pain. His pain is relieved by rest. He's tried anti-inflammatories, physical therapy. He's used membrane stabilizing agents, and he's had epidural injections. So what investigations do people want? I apologize for my dogs barking in the background. So
Please write on the chat, what investigation would you like?
So shall we answer it, or shall we ask the audience?
So you can read from chat, Mehmet.
Yeah. So, you know, I always believe you should start with X-rays. So here are his X-rays. These are standing AP and lateral. You can see that he has a little bit of asymmetric tilt at 4.5, and he's got a degenerative spondylolisthesis at L4.5.
Right. There are many different answers. Some of them are saying dynamic X-ray with MRI.
Yeah. So dynamic films are commonly ordered for this, but it's interesting. If you actually look, you're actually more likely to pick up an instability comparing a supine study to a weight-bearing study or a standing study than you are with flexion extension. And so actually, if you look at this gentleman's MRI, which I agree you do want to get, you can see that actually he reduces completely in the supine position. So you don't actually need flexion extension films here to know whether this guy is stable or unstable. The other thing to pick up on here is, I don't know whether no, I don't have a cursor here, but you can see the increased signal intensity in the facets. That's another marker. When you see that, if a patient comes in with who just has an MRI, if you see that finding, you know that they have a mobile degenerative spondylolisthesis. And now here's where I'd like to have the, you know, some of the board members, the faculty, et cetera, weigh in a little bit. Oh, these are the foraminal views. So you can see very severe L4 foraminal stenosis, a little bit of L5 foraminal stenosis. So
that looks like there is some degenerative list stages, huh?
Pardon me?
There is some list stages, I think, on the MR.
So I can't hear you, Mehmet.
Degenerative stages, I see some.
Yeah. It's degenerative listhesis, as Mehmet is saying.
Yeah. Yeah. So what do people want to do? So
injection, surgery, surgery, surgery.
He's already had injections. So an epidural injection at L4-5 gave him about 1 week of about 90% pain relief. He felt really good for 1 week.
That gives us the level of the pain management, pain generation.
Mm-hmm.
But one important point is that injections, there are different types of injections.
Yeah,
Not
this was done as a transforaminal epidural injection. So with small volume, and so pretty much localized.
I would consider doing also a facet injection.
Because?
Yeah, facet joint cannot be covered with an epidural injection, probably.
Yeah, but what information is that going to give you, or what treatment potential is that going to give you?
You didn't mention it, but probably you could have some signs of pushing the back, and on extension, the patient may feel more pain.
But again, I understand the but how is that going to affect treatment?
No, actually, if a test injection in the facets helps, then you can make a radiofrequency lesion.
But that won't really help with his dominant symptom is his leg pain.
Right.
I agree with Mehmet. I personally, in that case, I will do complete block of that level. I would go with bilateral facet joint and nerve root, and with small volume, as you said. So I will try to completely block that level. And then I will see, because I've seen that there is facet degeneration and open facet sign at level L5S1 as well. So I'm interested to see how much of his pain is coming from L4, L5 and from L5S1.
Well, as I say, he had 90% pain relief with an L4-5 transforaminal injection.
That is very positive sign for me, and that means that his level of pain generation is L4, L5, and I think that level needs to be operated. Because he has leg pain and back pain, I think we need to consider not only decompression, but we need to consider also some sort of fusion surgery.
Yeah.
With all the options based on, what is your preference maybe and what you can achieve. I would personally probably go for lateral approach or TLIF.
Sorry, lateral approach or
TLIF.
Anybody else?
If I would go for surgery, I definitely would go for lateral, because I don't think he needs decompression. So basically, just having a big cage, like Richard Asake was saying, and having a good segmental lordosis is a good option for me.
Just gonna go Hey, Doug, back.
This is, I gave that mid-lift presentation. I think with the facet sign, I'd probably do a fusion here. This is something that with expandable cage technology, I can get a nice lordot, big expandable lordotic cage with cortical trajectory screws, do it through a minimal access.
I agree with you, Mike. I think that this would be my approach as well. I would not do cortical, but yeah, expandable cage will give me good lordosis.
Would you do a trans-psoas lateral or more like the anterior to psoas lateral?
Pre-psoas for me.
Pre-psoas for me.
Yeah, and you can see here on the sagittal, this is the patient you do not want to do the trans-psoas.
Yeah, Mickey Mouse sign.
Yeah. This is the so-called Mickey Mouse sign, where the psoas muscle is very anterior to the disc space. These are the patients where the L3 nerve root is at very, very high risk. So this would not be somebody that I would, and actually, I personally don't do the lateral at the L4-5 level anymore because of the risk of the L3 nerve root. And then the other concern I have with the trans-psoas lateral is that would be a tricky lateral to do with the level of his iliac crests.
That's correct.
Possible, but tricky.
Yeah, at the end, the difference between some A-leaf, O-leaf, and trans-psoas is not that different sometimes.
Yeah. Okay. And we're coming up on our time call. So what I actually did, it's funny, if I were to see this patient today, this is one I did a few years back, or actually 15 years back, actually. I did this patient as a minimal access TLIF.
If I were to do it again today, I would do this as an A-lift with percutaneous screws. I have not gone to the O-lift currently because I've been doing A-lifts for so long, and I do my own approaches for the A-lift that in my hands, it's easier to do.
Doug, what is your choice of T-lift? What was that? From right or left?
I did the T-lift in this case from the right because he had the asymmetric collapse. He was down to the right. So I wanted to jack him up and level off the top of 4 when I did this. But as I say, if I were doing this today, this would have been done as an A-lift with percutaneous screws rather than a T-lift. And my reasons for doing that, 3 things. One is I get substantially better lordosis with an A-lift, particularly with higher lordosis A-lift grafts. Second, I like the bigger footprint you can get from an A-lift or a lateral. I think it's got a higher fusion rate. When I was doing MIS T-lifts, I was using BMP, so I was happy with the fusion rate, but I had a problem. I had about a 20% acute radiculitis, or about 1 in 5 of my patients that had an inflammatory radiculitis from the BMP. And then when I went away from BMP, my fusion rate wasn't as good. And so that's why I've gone to more anterior approaches like the lateral or the A-lift approach.
Yeah. Thank you, really. It was good to discuss it with the other options. But nobody has said XLIF, I think, or transpsoatic approach.
Well, we did mention, I think this, as I was saying, I think this is exactly the wrong patient to consider the transpsoatic.
L4-5,
not just the L4-5, but particularly this appearance on the axial, where the psoas muscle is anterior, the anterior margin of the psoas muscle is anterior to the vertebral body.
Right.
This is the so-called Mickey Mouse sign. And these are patients where the L3 nerve root is at very high risk. And even the really big advocates of transpsoas would say this is the patient that you should avoid doing transpsoas on.
Thank you, Doc. I think we are out of time and we must stop it here, the case. Thank you. Thank you a lot.
Thank you so much. Next, we have the session of question and answers with Professor Ed Benzel on how to become an academician. And for that, I would like to request Professor Michael Steinmetz to lead the session.
Thank you very much. So this is going to be hopefully a very interactive session. There will not be any slides. This is our opportunity as participants, especially the younger participants on this meeting, to ask Ed Benzel questions. The theme is becoming an academic spine surgeon or becoming an academician. And so I'd like to invite the audience to write their questions in the chat box, and I will attempt to moderate those questions and ask Ed questions. And I'll kick this off. And I think if we don't start getting some questions in, perhaps the other faculty can ask some questions too while we're getting people to type in their questions. So Ed, are you there?
I am here.
Ed, so I had recently seen an email that you had sent out about a book you and I are working on about someone from another country, and his quest in life was to become someone like you, and hoping to be someone like you as sort of the pinnacle academic spine surgeon. And I guess the question that I would ask you, and there's no specific, I guess not one specific answer, is if I am a medical student that is now just getting into orthopedics or neurosurgery, how do I start? Like, how did you start? What did you do early on in your career that helped you get to the point where you're at now?
Well, I really started as a resident working on manuscripts and research with Dr. Sanford Larson. And then early in my career, teaching and writing a lot. And it's just like the rock and roll group Rush's song Roll the Bone. The key to hard work is the key to good fortune. And so I wrote often, I read a lot, and I spoke often. I didn't turn down when I received an opportunity to speak. I didn't turn it down. And I focused on having other people help me, which I literally refer to as hard work, hardwiring my environment, whether it be nurses on the ward or the operating room, clerical people, associates, fellow residents or medical students, and in turn, always treating them well to create an enriched environment around myself. And so it wasn't me who succeeded, it was all the people who assisted me throughout my career who succeeded. But I guess if I did anything, I put them in the position to help me and to want to help me.
Yeah, that's actually good advice. So where I think a lot of us fail at is getting the environment right around you so that you can be successful, which is very introspective. And I think you told me once, write early and write often. And I hear you say that as well, certainly early on in your career is a way to advance sort of the academic aspect of our job.
So I have another comment here regarding preparation for talks or meetings and things like that. People will often say to me, oh, you're just a natural, you don't have to prepare. I'm guessing that for every hour I speak, I am preparing every time, 2 to 3 or more hours. I work hard at making sure I have all my T's crossed and I's dotted before I get on the podium.
Also great advice. To all the participants, please type in your questions for Professor Benzel so I can ask him. All right, I'm starting to get a few coming in. So a question that just came into the chat, Ed, is when you look at academia, it's both teaching and research. And obviously one person may not be as strong in both areas. How do you balance that? How does one balance being a good teacher versus it being a good researcher or trying to do both?
Well, I think both are important, but from a notoriety perspective, teaching and public speaking is probably the most important. I don't know how to balance that. I think you simply must do both. You don't get asked to speak unless you've written something, usually. I'd say the greater balance issue is the work-home balance. I like to say that we physicians need to be selfless and dedicate ourselves to our career, to teaching, to our patients, etc. But we also need to be, on the other hand, need to be selfish and striving to get home on time to be with family, etc. It's a tricky road to hoe.
Oh, very true. So that's the only question we received so far. Please, our audience, type in questions that you've always had interest with regards to Dr. Benzel. Okay, so, here's another one just came through, Ed. This is something that's dear to your heart. When you look at becoming a spine surgeon, should I go into neurosurgery or should I go into orthopedics? Which one is better?
Boy, that could get me in trouble, couldn't it? Neither is better. This is near and dear to my heart because 20 years ago, we started a combined, over 20 years ago, started a combined ortho-neuro program with medical spine specialists, and every single person in that program, orthopedic or neurosurgeon or medical, puts their pants on one leg at a time. And we treat each other as equal. We are equal. We respect ourselves as equal. So my answer to that question is dealer's choice. In general, orthopedic surgeons come from a more mechanical, biomechanical slant, and neurosurgeons come more from a neuroanatomy slant. But at the end game of spine surgery, except for intradural work in most countries, both are the same, and they're becoming more and more similar. But I still think it's very important for us to have both specialties, because there are overlapping rings, the orthopedic ring and the neurosurgery ring, and each of those edges bring something to the middle that is very valuable. It's palpable in our program at the Cleveland Clinic.
Yes, that's a great way to present it. Now, you know, so everybody knows on the call in our department, there's 9 of us that do spine surgery on the main campus, both ortho and neuro, and it's hard to know nowadays who's ortho and neuro. And I always joke, one of my partners, Tom Raz, who's an orthopedic trained spine surgeon, is much more of a neurosurgeon than I am with the type of surgery he does. So the lines certainly are blurred. All right, Ed, here's actually a very insightful question. So when we look at training today, the question's around neurosurgery, but I think it's equally applied to orthopedics, is everything is diversifying and sort of becoming a subspecialty type job. Time, we're seeing residents have less time or less exposure to each of these areas. How does someone going to choose what area they want to go in as their exposure to those areas continue to diminish?
Well, I talk to students and young residents a lot about this. Interestingly, we used to take a look at graduation at the graduate's personal statement when going into the training program, and almost invariably, the graduating resident chose a subspecialty of neurosurgery that was completely different than what they thought they were going to do 7 years prior. And so my recommendation here is to flow with it. You know, it'll grab you, at some point. And if you're getting quite far through your training and it still hasn't grabbed you, then maybe you need to talk to some mentors. But usually keep your eyes open, because there are many things that people, particularly young surgeons, don't see yet, and hopefully they will see them as they meander through the educational abyss.
So Ed, here's an interesting question. If you were able to start your career over again, would you have done it differently?
I see Doug smiling. I'm looking for a clue here. First of all, the time and the place where my career developed doesn't exist in the United States anymore. I trained with arguably the first neurosurgical academic spine surgeon, Sanford Larson. I was arguably the first neurosurgery spine fellow under his tutelage after I graduated, the first year postgraduate. I went to Louisiana State University in Shreveport, and it truly was the wild, wild west there. I didn't work with neurosurgeons. I worked with orthopedic surgery residents, general surgery residents, ENT residents, and I created an academic and clinical mini empire, if you will, that was very productive. This doesn't exist right now. And there's fundamentally, when I talk to people about academic jobs, there's really 2 ways of looking at your first job. You go to it, one is to go into an environment where there are other specialists doing what you do, and you start at the bottom and work your way up. Or go to a smaller institution, which is more like what I did, and be near the top of the ladder from the very beginning, which requires a lot of work, a lot of time, and a lot of blood, sweat, and tears. That was the route I took. And I think young people going into practice out of residency fundamentally have those 2 choices. Very few take the hard work choice, though, these days.
Hey, Ed, that's fantastic. So some of the questions and comments that have come in are around mentorship. And, you know, obviously you've been a mentor to so many, but when you look at it from, say, a trainee's side who's on this, what advice would you give them to picking the right mentor or an appropriate mentor?
I would probably not necessarily be enamored by the buzzers and whistles and bells and sparkles. In other words, the accomplished mentor may not be a good mentor. I would go with my heart and go with a person whose fundamental beliefs are doing what's right. Because what I would want is the guidance to get into my career, jump into my career with the greatest chance of being successful. I like to use the term doing what's right. It in the long run serves people well. If I could just describe a definition of leadership, which is more or less like a servant leader, and that is leadership is the art of causing others to do something they otherwise would not have done. And so developing those skill sets really requires of the person to have strong social and self-awareness skills. And so if a mentor can help a mentee develop those skill sets, that is perhaps the greatest gift a mentor could give to a young surgeon.
That's excellent. That's great advice. Ed, there's a question around, there's a couple questions around training as a spine surgeon. One is, you think we will have a future where spine surgery becomes its own specialty? And then sort of connected to that, but different, is as an orthopedic surgeon, as a neurosurgeon, we train to do so much, yet we limit it to spine. Should we, in this field, should we try to do mainly spine and less of everything else? Can we find balance between doing cranial and spine surgery, or hip and knees and spine surgery as examples?
This discussion has been ongoing for decades. The gray hairs in both specialties, ortho and neuro, of which I am one, I guess, except I have no hair, have been very rigid. You know, we've got to preserve neurosurgery and you know, screw the orthopedic surgeons and vice versa. And yeah, it does seem a shame for someone like me when I was a rookie to learn how to do aneurysm surgery and pediatrics and tumors, etc. And then to not do that anymore. And honestly, my thought process is here. I do, on the one hand, think that we need to preserve the sanctity of both orthopedic surgery and neurosurgery. On the other side of the coin, if you look at most neurosurgery programs, we could finish our training in 4 years with the fundamental aspects of neurosurgery and be probably very well trained as a general neurosurgeon. And I'm sure that would be true for orthopedic surgery. Then possibly have fellowships be longer, where those research years don't occur. We have 2 years of research in our program, at neurosurgery program at the Cleveland Clinic. Then that research would occur in a 3-year or so fellowship. So less time would have been spent. Less, probably not so important time would have been spent in other aspects of orthopedic surgery or neurosurgery, and more time in training would be spent on spine surgery. But that's just my thought. I have no idea where we're heading down the road.
So Ed, let me perhaps ask one last question here, and so leave us a little bit behind, but this has been an incredible, valuable experience for all of us. And I'm trying to figure out how I will ask this to you, but we're talking about becoming an academic spine surgeon. We're also today showed a lot of technical surgery that costs a lot and is fairly high, is fairly advanced. What advice can you give to those that are in resource poor environments where, again, it's hard to write because there's not as much support, nor are they really having the access to these higher, these greater technological advances in spine surgery, and then it's hard to write about that as well. And since the question is sort of the standard of care, if we call it that, is now advanced beyond what certain areas can offer.
Yeah, I'm going to talk about this a little bit in the future of spine surgery at the end of this session today. First of all, I think all of us, need to really focus less on technology and more on thinking through things. And we used to call this divide first world, second world, and third world countries. And most of what we've been talking about today have been first world problems. They are not problems that are commonly addressed in middle income and low income countries. And yet the vast majority of the patient population of the world live in these countries. There needs to be some sort of redistribution of resources and intellect and restoration of and minimizing unnecessary operations or less than optimally necessary operations. And I'm going to address that in my final talk. If I could just in closing emphasize one word, and I think it has been exhibited throughout our sessions here yesterday and today, and that one word is fun. We need to make our work fun. We need to make our collaborations fun, because if they're not fun, we're not going to be as productive or achieve the heights that we otherwise would do if we just loosen up a little bit, take off our tie, put on our hat, and go to work in a positive environment.
Great advice. That's certainly advice we can all live by. So Ed, thank you so much for this. This is, I think, a session we could easily go on for an hour or two with the number of questions that have been sent through the chat room. People are really heeding your advice, and I think I can speak for all of us and say we appreciate it and appreciate all the knowledge and advice you give us as participants in this meeting. So on that though, let's close this session and let's move to the next.
Thank you. So for our next session, I'd like to request Professor Zia Gokaslan, from USA, and Dr. Sandeep Vaishya from India to moderate the next session.
Well, thank you so much. First of all, it's a pleasure to be included in this session as a moderator, along with my co-moderator, Dr. Sandeep Vaishya. And we have two outstanding keynote talks coming up. One is on the future of minimally invasive deformity surgery, and the next is on the concepts of craniocervical junction and spine instability. So I'm going to go ahead and introduce the first speaker, Dr. Michael Wang, who is a professor of neurosurgery, as well as the vice chair in the Department of Neurosurgery at the University of Miami in Florida. Dr. Mike Wang is also the director of the spine program there, as well as their fellowship training program. Dr. Wang is a world authority in minimally invasive spinal surgery and in the surgical treatment of degenerative spinal disorders. He really is a thought leader, is an outstanding technician, and he's one of those early adopters of new techniques and their application to spinal surgery. So we all look forward to Dr. Wang's talk.
Oh, thank you, Zia. Thank you for those are very kind words. And this dovetails nicely with the comments that Mike Steinmetz and Ed Benzel just made. let's see, let me share my screen here. And let me just start by saying that this is really a fantastic opportunity. I want to thank Lily Angelov and the folks at the Cleveland Clinic for inviting me to this. This is definitely the most inclusive and diverse, and I don't mean that in an American sense. I mean, group of surgeons I've seen in a long time, the balance across 6 continents. My hat's off to the folks at the CCF for putting this together, and Dr. Sharif as well for congratulations on your presidency. So this is probably the best use of Zoom I've ever seen. We are all doing a million unnecessary Zooms, but this is one capacity where if you look at, and I'm not a left winger, but the carbon footprint or the expense of traveling and getting us together would be onerous and the time consumed. So congratulations, and maybe this is something that goes forward in the future. Although we'd love, as Ed said, to be fun and together as well. That is certainly not something of the past. So I've been asked to speak about an area which I have a lot of passion for, which is in the area of MIS deformity surgery. And this is currently sort of a first world problem, but also I wish that I'd put in slides to indicate how it's applicable to the third world as well. And so this is your typical type of MIS deformity case. This is where we're at. This is a T9 to the pelvis instrumentation and correction for a lady. And what you can see is these are the sort of the parameters on what we're looking at. So when you look at an MIS deformity surgery, it's still a big operation. It's still a big enterprise. It's still a surgery that has morbidity and cost and on very sick and old people. And I suspect that maybe in response to the comment that Ed made, that they may be able to, in the second and third world, leapfrog us in many ways, like how Australia leapfrogged much of the Western world in terms of their social orientations. Maybe that MIS complex surgeries will leapfrog in Asia, in India, in China. And we certainly see that on many realms where China is way ahead, or Korea or Japan are way ahead of us in America. So this is what's going on. And there is building, if you will, a set of data on the issues of MIS deformity surgery. Many of the experts are on this faculty. I see Richard Asseker's on and many others, Mike Steinmetz, who do this type of surgery. And if you look at the growth of this is sort of giving you an idea of publications. I love that Ed, as editor of World Neurosurgery, is talking about with Mike about the issue of if you're using sort of more last decades technology, how do you even publish, right? I think that's a really important, maybe it's going to be an editorial in the future, but this is deformity surgery in the MIS realm. You can see if you go back to 2008, just 10, 12 years ago, just a couple of papers, and now really building steam. And you're going to see papers coming out of China soon. It's really going to build a head of steam, and the technology is constantly changing. But why is there interest, right? And this goes back to those last comments. This is some of our panelists are from close to this area. Americans relish this idea of Everest as being almost legendary in our minds, and some of you live close to that area of the world. And so if you think about it, you know, the idea of trying to reach the summits or challenging yourself, and if you put it in that realm, MIS and deformity are exactly where they intersect, right? And in the US, this is a paper by one of our least liked individuals, if you will, which is Richard Deo, who's been the clarion call. He's not a surgeon. He's like a geriatric doctor, talking about how there's so much unnecessary spine surgery and the proliferation of complex spine surgery. And I've talked a lot in the past about how I think this is sort of a ruse. It's a question of classification and how the problems are, because if you look at the growth of, say, injections, and I love the conversation about the injections earlier that Doug Orr had, that has grown many, many times greater than spine surgery. I think the difference here is the need of the population and the desire to get through this. But spine surgeons, you know, we have a unique role. And this is what you do if you go to Google. It will self-populate the end of like your wife or husband, it will complete your sentence, right? So if you type in is scoliosis surgery, it comes up with these first 10 completions. Take a look at that. And let that soak in for a minute, because spine surgery, and I was having this conversation yesterday with Mike Apuzzo, is the only realm of surgery I'm aware of where every single patient has heard, don't ever have that surgery. There is nothing like it. Hip surgery, brain surgery, plastic surgery, urologic surgery, doesn't matter. Only us. Only do we have this. And look at this, you know, I'm not perfect. No one is. I have screws and rods. I'm a spine surgery survivor, right? That's how we are viewed in the world. So I'm going to talk about you know, I could talk about advantages like reducing costs, preventing PJK, clinical improvement, coronal and sagittal correction. I'm not going to dwell too much on that because you can find that 15 minutes is not enough time to talk about that. Instead, I'm going to talk about these three broad areas very much at a 40,000 foot view, which is number one, which is what Ed commented on, what we shouldn't talk about is leveraging these advanced techniques. Number two is how technology is going to change how this is done. And number three is the application of MIS as a realm of thinking, not of technique per se. So advanced techniques, right? So this is the typical talk. This is as Juan Uribe would say, the butterfly collection, right? This is where you show off all your best, perfect X-rays and hide the ones that didn't look so good, right? So I showed you this one already. This is a case where you can see by using posterior instrumentation, you can get good correction. Multiple ways of doing that. We published this in multiple realms, if you will, about how to do multiple level interbody surgery and get corrections. And getting corrections in a way that can treat sort of intermediate deformity, not the very, very severe ones, but the intermediate and maybe, if you will, the more flexible deformities, right? So we had to get to better or more powerful ways like MIS PSO, mini open pedicle subtraction osteotomies, where we can do very, very substantial corrections, fixating above and below. And again, with this audience, I don't want to get too wonky about all the technical features. You can look this up in the papers that we've written. Using a 4-rod technique, Richard Osseker had a role in teaching me this and breaking the spine and getting control without having to open up the spine and seeing the spinal column, which is what this society is about, maybe treating the column without seeing the column, right? And breaking the spine at the PSO site. And this was published. So you can look at these papers. I don't want to dwell too much on the pros and cons because there are pros and cons of everything that we do. With this type of technique, of course, you're doing a true 3-column osteotomy. You're able to correct very, very substantial deformities up to the limits of the most severe ones, right? Of course, lateral, we hear a lot of discussion about lateral and anterior surgery. Doug mentioned this about the A-lift, O-lift, X-lift, D-lift, all these approaches being used, new routes being invented every day that are differing by a millimeter or two, and then someone coming back and saying, I invented that 10 years ago. But the reality is this is an important realm because it's changed how we think about indirect decompression of the spine. This shows the growth of interest in this area. But I think the basic principles here are the key. So here's a lady who had a long segment fusion as a teenager, had a flat back, and came in. And you can see what we did was we just focused on the bottom of the construct, and she had L4-5 fused already. So she had 2 surgeries, right? She had an L4-5 lateral, and we just did an A-lift, and with a 1-level surgery, we're able to get her what she needs. She works in our hospital, so we see her every week. And so you can see that this is an MIS concept. You could say A-lift is MIS or not MIS. That's not really the point. It's not about tubes. It's about looking at this as a concept, and we'll come back to this. And focusing on using hyperlordotic cages. We heard that nicely discussed by Mike Steinmetz. And of course, Luis Pimenta talks about the trans-psoas approach. This is the ISSG group. Nobody's not heard of the ISSG group. We have an MIS realm where we've been looking at this under the leadership of Shay Bess and Chris Shaffrey. And this is just one of the papers that we've had. There are numerous papers. This shows the amount of curve correction you can get versus the preoperative curve and all these sorts of types of approaches, whether you talk about a blue surgery, which is the standalone lateral, the green, which is like a lateral plus perk screws, or the red, which is where you open the back. And what you can see here is that you can add lordosis with all these techniques. But here's the most important slide. This shows getting the LL to match the PI. And if you look at that, people use different techniques based on what's needed. So the important thing, as Ed was saying, is doing the right surgery on the right patient. So in the expert group, you know that some techniques are more powerful than others. You've got to apply the right technique because as the techniques get more powerful, they also become more morbid. Here is the MIS DEF algorithm. Praveen Mumanini gets credit for this. This is in its 2nd and 3rd iterations. Now, please look it up. There's not enough time to cover it. We could do 15 minutes on that alone. Of course, the latest development is the ALL sectioning, going in and sectioning the ALL, being able to basically fish mouth this like the old Smith-Peterson osteotomies. And getting tremendous correction, almost like an A-lift, but higher up at areas that if you've been fused down below. And the ACR has been very powerful in that realm. So you can see the ACR level here at L2-3 getting tremendous correction. So Juan's really published a ton about that. He even has a new classification along with the Schwab classification to show that. So the second area I want to get to is the new or high technologies, right? And what I'm going to focus on here is making good surgeons better. okay, that is leveraging technology. So maybe, if you will, and Ed says a fool with the tool is still a fool, but some people just need to have a little bit of an advantage, like maybe I'm not as good a driver, so I need like a lane departure warning for my car, right? This is the first MIS deformity surgery that was cataloged. This was, we call this a Hollywood curve. This is Greg Anderson from the Rothman Institute, an orthopedic surgeon. But of course, we know navigation robotics is changing all of this. I'm not a big fan of this, but I know it is the future. This is changing everything about how we plan and think about surgery. If you think about how people come to surgery and just kind of work with the problem, this allows us to plan ahead and think ahead about what we're going to be doing to a patient. And that may be the biggest advantage of this type of surgery. You can think about screws being loaded ahead of time in places where maybe you can't have all the full selection of instrumentation available, right? And this is just a cataloging, as we talked about in America at a national meeting, the Congress of Neurosurgeons, the number of robots that are out there right now. There's now 20 robots out there, and they all do different things, and they're all very special. But this is really where it comes down to how the robot's superior to us. This is a Da Vinci robot, which we don't use in spine really, putting together a sandwich. And what you can see is that you have 2 hands, you have 10 fingers. The robot is not confined that way. The robot hand could be a couple millimeters or it could be 7 meters. That's the power of the robot. It's not that the robot's taking over the surgery. The robot is not anthropomorphized. It is not linked to the human body and our genetics. It can be built however we want to build it. And that is the true power and value of robotics. Technology is super attractive about dealing with all kinds of things in deformity, like the abnormal and atypical anatomy and tissues, and it relieves the stress on the surgeon. Think about one part. Let's just say, and people say, well, it just puts in screws for now. Let's just say the screw part is the stressful part for you. If the robot can do that for you, there's a real advantage. The last part is applying MIS principles, right? And that's in the spirit, as Rick Fesser would say, of doing minimally disruptive procedures, meaning don't poke the bear. There's a lot of cases, you know, where deformity was partially treated, and maybe that was or wasn't enough, right? And so Tony Tenori taught me this. He says, the goal is not to make the patient 18 again, it's to make the patient the way they were before the pain really got bad. And that's a very important take-home lesson. So here's an example of a doctor's wife. This person's had scoliosis her whole life, right? She has a radiculopathy, right? And she has foraminal stenosis. Does she need a T10 to pelvis, as 8 other surgeons told her? Absolutely not. That is not the surgery that's needed here. We do an endoscopic decompression. I heard that on the last chat. You guys can't all see the chat. Just doing an endoscopic focal decompression gets her the relief of the sciatic pain. Will it last forever? Of course not. She's only 66, but maybe it gets her where she needs to be for 5 or 10 years. And that's the idea. And here's another example trying to treat just with 1 level fusion, the focal area, right? So the idea is to reduce the rate of iatrogenic problems. It can be good on the frail and ill patient, reducing complications, attacking a problem piecemeal. Let the patient live to fight another day, right? So again, the results have to be measured against open surgery, which is still the gold standard. Shameless plug for our neurosurgery podcast. Ed's been a guest on this, one of the most subscribed to episodes on our podcast. Thank you very much. Congratulations on a fantastic meeting.
Okay, here's the poll.
Can I ask a question of Mike?
Sure, Dad, go ahead.
How can we talked about, you know, high income and low income countries, or first world and third world countries with widely disparate resources, et cetera. How can we leverage the technology you're talking about to help every person with spinal disorders in the world?
I love that question, Ed, because it's all about that, right? So I don't know if Rick Fesser is still on or not, but Rick published a great paper. It wasn't well controlled, but I think it was him versus Tyler Koski. So just for the people who aren't in America, the event-related acute costs of a deformity surgery like a T10 to pelvis at Northwestern was $500,000 US. Right? And Rick was able to reduce that to like $300,000. Now I know cost numbers it's really not $500,000, but let's just say it's 100,000. The ability to reduce the cost of the surgery through less disruption is really tremendous. And of course, it's all about scaling, right? Because the first computers were the most expensive, right? So as soon as we scale, everything's going to change. And that's where, you know, I went to school at Stanford, and the folks there are always thinking on the West Coast, thinking way ahead. We know that what we do is super expensive. BMP is priced to market, but BMP does not cost that much to make. So it's really a matter of understanding this piece. And I think China, you know, with all of its power is doing this. Now, part of it's patent violation. I totally get that it's politically very charged. But the reality is that we're going to get there. And I guess I'm probably not young enough to see it, but it's coming really fast and heavy. And in countries like Pakistan and India and China and Indonesia that have huge populations, they're going to crack this code. America's just leading the way with the technology.
Okay, thank you.
That's my opinion. I mean.
So the next speaker would be Dr. Atul Goyal. Dr. Atul Goyal doesn't need any introduction. He is one of the most innovative surgeons of our generation. He single-handedly has changed the CV junction surgery, and I think he will be speaking on concept of CV junction and spine instability.
Can you hear me? Can you hear
Yes.
me? Okay.
Yes, we do.
Okay, so I'm here to introduce to you a new concept and probably a revolution in spine surgery. The title is Instability is the Issue and Stabilization is the Treatment. For several decades, this is basilar invagination. For several decades, decompression was the treatment. Anterior decompression here and posterior foramen magnum decompression here. This was the first article in the literature in 2004, where instability was identified in this group of patients and stabilization was the treatment. Decompression, however, remained treatment for this. So this was the first article where craniovertebral junction realignment and stabilization were considered as treatment, not decompression. So this is basilar invagination. Realignment is one thing and stabilization is another thing. I consider stabilization as the more and most important issue in this problem. In the year 2009, we introduced a new concept, which is I also consider a revolution in the field of spine surgery, the issue of central or axial atlantoaxial instability. So you please see these slides. This is stability type 1, where the facet of C1 is in front of facet of C2. There is atlantodental interval disturbance. There is cord compression. There is facetal listhesis, and facetal stabilization is the treatment. This is type 2, where the facet of C1 is behind the facet of C2. This is basilar invagination. There is no atlantodental interval disturbance. The whole world will still do foramen magnum decompression for this anomaly. This needs atlantoaxial stabilization. Even when the facets are in alignment, even when there is no atlantodental interval disturbance, presence of Chiari malformation and syringomyelia is an indicator of atlantoaxial instability and needs stabilization. When atlantodental interval is not disturbed in type 2 and type 3, these are central or axial atlantoaxial instability. So basilar invagination, no matter whether it is group A or group B, it needs stabilization. And we have introduced this subject in several articles on a basis of huge number of patients. Now our experience on this exceeds or nears 3,000 cases. So whenever there is, even when there is no atlantodental interval disturbance, presence of Chiari malformation and presence of syringomyelia is an indicator of an unstable atlantoaxial joint. You stabilize and you create wonders. There is no need for any kind of decompression. Even when there is no facetal abnormality, even when there is no atlantodental interval disturbance, presence of Chiari is a clear indicator of atlantoaxial instability. And now we have got several hundred patients where these are treated syringomyelia Chiari without decompression. And I consider decompression as a negative operation and reduction of syringomyelia. So there are several articles. In 2008, we said basilar invagination, syringomyelia, Chiari formation needs atlantoaxial stabilization. And in 2013, we said there is no question, no doubt about it. Similar philosophy I related to degenerative spine. This is one of the very early articles when degeneration of craniovertebral junction was discussed as an issue. Otherwise, there was never an article. Presence of osteophytes, presence of reduced facetal space, presence of buckling of posterior longitudinal ligament. We said that these are not primary events. These are secondary to atlantoaxial instability. Extremely important statement to make. Presence of ossification in the apical ligament is not a primary process. It indicates atlantoaxial instability. It indicates the need for stabilization. Retroodontoid ossification or pseudotumor was considered to be a surgical issue, direct surgical issue, and number of articles have been written. We said for the first time in the literature, there is no need to remove this retroodontoid tissue, which is like an osteophyte. Atlantoaxial instability is the issue. You stabilize, this will reduce on its own. And this was, there is no question, this was a dramatic article during those days. And after this, there are several articles which discuss this issue. Retroodontoid cystic degeneration is not a primary process. It indicates atlantoaxial instability. You stabilize, this disappears. And this we have published. Retroodontoid pannus is in rheumatoid arthritis is not a pathology. It is due to vertical instability, and you stabilize, this pannus disappears as early as immediate postoperative period. No question in my mind. This concept revolutionized the treatment. Otherwise, transoral surgery was a very in thing for this problem. Vertical instability is the issue in spinal degeneration. Take it from me. Take it from me. This kind of facetal instability for C1, C2 in basilar invagination, everybody knows. We do not know. We never discuss retrolisthesis of facet in spinal degeneration. Reduction of the joint space, bulging of the disc bulges, osteophyte formation, multiple level bulges are not primary events. They are indicators of spinal instability, and they indicate the need for spinal stabilization. This will disappear spontaneously. This whole world will come and remove this. But there is another form of treatment, distract the facet, introduce these spaces, and you can treat by facetal distraction. In the immediate postoperative phase, you can have a new disc, ligamentum flavum goes, bulge goes, and the patient improves dramatically. So there are several hundred cases with me now where this ligamentum flavum bulge, facetal disc bulges can go immediate after operation by multi-level facetal distraction as a treatment. And this we published in the year 2011. With these kind of spacers, we introduced similar concept in the treatment of lumbar canal stenosis in 2011. But now we change. Decompression of compressed or deformed neural system has been the basis for treatment. We do not agree with this. We say that only fixation for spinal cervical spondylosis is the treatment because instability is the cause. I introduced this concept in 2013, and that we recently published our experience with 215 cases with this concept that instability is the problem and stabilization is the treatment. Decompression of any form is a negative treatment. No need to remove this. No need to decompress this. Only need to stabilize this. This is the treatment. And there is no doubt or no question in my mind when I say this with such confidence and such pride that there is no need for decompression, there is a need for stabilization. Atlantoaxial instability is frequently present with spinal degeneration, cervical spondylosis. When you see multi-level spinal degeneration, you never look at C1, C2. When there is no compression here does not mean that there is no instability. You see, there is a big instability, and that I call central instability needs stabilization. When the patient is remarkably disabled, cervical spondylosis, atlantoaxial instability is very commonly associated, despite the fact that there is no compression. Decompression is not the treatment. Stabilization that includes atlantoaxial joint is a magic. You please take it from me. Lumbar canal stenosis, we introduced the same concept that degeneration is not degeneration, it is instability. Even when there is a huge osteophyte or disc bulge, it is an indicator of unstable spine meriting the need for stabilization as a form of treatment. Ossification of OPLL, nobody in the world knows treatment. The only treatment described is decompression. We introduced a remarkable, probably a revolutionary concept that atlantoaxial instability is very common phenomena in OPLL. This is OPLL. Decompression is the treatment. You do laminoplasty, you do corpectomy, and all kinds of decompression it has been indicated in the world literature. I am saying with great pride and pleasure that these patients need only stabilization, and decompression as a form of treatment is a negative form of treatment. Is only stabilization a form of treatment for OPLL? Absolutely. And there is no doubt. And there are several papers where we have mentioned our experience as only spinal fixation as a treatment for cervical myelopathy associated with posterior longitudinal ligament ossification. You see, there is ossification of posterior longitudinal ligament, and there is an instability here, even when the facets are in alignment, even when there is no manifest or radiologically identified instability, even when there is no compression at the C1, C2 junction. Presence of OPLL such high is an indicator of atlantoaxial instability, meriting the need for stabilization and absolutely negating the need for decompression, whether it is anterior and posterior. Both these forms of decompression are negative forms of treatment. This is an OPLL. This needs atlantoaxial stabilization and subaxial stabilization, decompression, laminectomy, removal of osteophyte, removal of disc, introduction of corpectomy or laminoplasty are negative forms of treatment. Atlantoaxial and subaxial spinal fixation, can it revolutionize the treatment of OPLL? Absolutely, absolutely. Can decompressive laminectomy for degenerative lumbar and cervical canal stenosis become historical? Absolutely. Is instability the nodal point of pathogenesis of both cervical spondylosis, myelopathy, and OPLL? Absolutely. I am introducing before you, I am introducing before the World Spinal Column Society an absolutely alternative, revolutionary concept. And you please carefully read these lines. Decompression is never primary. Decompression is always secondary. Treat the primary. Decompression is never a form of treatment. Thank you very much, my dear friends.
Thank you so much. Next, we'll be finally going to our quiz session. For that, I would like to request Professor Doug Orr, Professor Mike Steinmetz, and Joachim Ortel to moderate this quiz.
Okay, unfortunately, Mike has had to go off to a meeting, so it's just going to be Joachim and I. So we have our players. We seem to only have 4 so far. This okay.
So Doug, I have to write everything down. Is that right?
So you just write down the scores.
I have no backup then this time.
I know. I will also try and write down the scores.
You have been disconnected.
दोबारा connect करो. So I only see 4 players.
No, sir. 2 players have connected.
All right. Sorry for the delay there, folks. Okay.
Only 2.
Yeah, but waiting for others. Two are disconnected right now.
Two is very nice. Then they all get a prize.
So we'll give it a few minutes for our people to connect up again. So the way this is going to work is we're going to have 25 questions. The questions are not multiple choice. The questions are single answer questions. I'm going to read the question off, and if you think you know the answer, players press your buzzer. The way the buzzer will work is it will know who did it first. They get the first chance to answer. If they are correct, they get 100 points. If they are incorrect, they lose 200 points. So, and then at the end, if we have a tie, we will have 5 further questions, and whoever gets the best score out of the 5 will be our winner. So currently, it looks like we have 3 people connected
We have
and 2
to
disconnected.
wait for 2 or 3 minutes to join them.
There were supposed to be 10 players.
Well, the limit is 200, it says.
Yeah, but we only wanted 10.
200 I cannot write down.
Yes.
Wi-Fi. अमानवी क्या कर रहे हो? डिस्कनेक्टेड क्यों है? ये अमानवी इधर खेल रहे हैं, पता नहीं क्या
What
कर रहे हैं।
happened to Wonka Bowich? He was just there. He left.
यार इनका नेट खराब है।
Where are the other players?
Sorry, sir.
Where are the other players? We can't keep on waiting.
How are you?
Why are these people disconnected?
One is gone. It's Wonka Bowich or something. Was connected already. He's gone now.
Yeah, Yusuf has just said on the chat that he was disconnected in the Zoom, so he's coming back in. So how many people do we have at the moment?
3. You stay with 3. Oh. Amanullah is double. This is not possible. Sorry about this.
Okay, so we're waiting for, what about others? Where is Usman and
Where's Nida?
can you guys call and just check what's happened?
No, at least we have 4.
We need to have more. Come on, guys. Just call and check.
What is Sheikh left? And Wonka Bowich was in, but he left. Or
So
she
we
left.
have-
I don't know.
We have numbers,
Dr.
so we're
Nida is
calling them.
coming, she said.
Sorry?
There are 2 people we know are trying to join in. They went out of the Zoom.
Overall, the internet worked very well, I think.
Yeah,
Very
yeah,
well.
I think-
Except
Did
for
not
Rick
expect it to be
Fessler.
that.
On the last update from Rick Fessler is he's working with Comcast to get his internet to work. And if you know anything about the company Comcast, that is not a positive thing.
Okay, so people who are joining, we don't know if one of them is. We will wait for 2 more minutes or something. Doug,
Yeah,
what do you think?
2 more minutes.
So otherwise, tough luck.
Oh, somebody's doing online shopping.
Online shopping Pakistan is on the lower right.
It's showing Daraz online shopping Pakistan
Whose
inbox.
screen is this?
This.
You have to listen and watch.
So this is Imad doing some undergarments.
Yeah. He tried to catch some new players.
So Usman is joining. Usman is one of the guys who are playing.
Okay.
No, well, this is, I don't see him.
No, he just joined in. So it says joining.
So what about the two left?
Nida and Yusuf.
Amanullah? Can we
Amanullah is
call
already
this
in.
guy?
Yeah,
he's already in.
Amanullah is not, he's in. Then Strike is missing.
So we have Yusuf Sheikh and we have Nida. Two of them we know who are trying to get in. Nida has just come in.
And Vonkabovic?
So we are checking on that person at the moment. So this is fun trying to get people in.
She said it's not working.
So he's saying Buzzin is not working.
Yeah.
Yusuf is already in Zoom, but he's saying that he's trying to log in and he cannot get into Buzzin.
Even Nida cannot get into Buzzin.
Then what we could do is we could have all the participants on the screen itself, and you want to ask question and say who answered first or what? If you're having
How
trouble.
can we decide?
That's going to be difficult.
This is impossible. How do we know who pressed the button first? It's impossible.
1 second.
Okay, one more, a new one, Anthony.
So both Nida and Yusuf are in Zoom, but they can't get into Buzzin.
Now we have to find out whether it's their fault or Buzzin fault.
They are in Zoom at the moment.
No, this is not what is required.
Yeah, because we can't control who's on the screens here.
That's impossible.
Ask them to try one more time, and if it works, fine. Otherwise, we have to
we
move on.
tried this Buzz thing. It worked fine on Friday. When did we try? On Thursday.
We tried twice. We tried ourselves as well, and it worked very well.
Okay, well. We have an audience. Now we just need participants.
No, but we don't have those two who are on Zoom, but they can't get in. Is there any way? No. But basically what they're saying is that website is not opening for them.
Could we start another game and send out another code?
Can we send out another code, restart, and then everybody come in again? Come on, we have to do this now quickly because we don't have time. Okay. So let's get another code and we'll send it to you. Can you all disconnect then? And then reconnect again, please. So sorry, everybody. I apologize.
It went perfectly fine on us when we did the trial.
So we have done this even in our morning meetings as well, and we've done quiz in the morning meetings with this, and it's worked well.
What is the price in the morning meeting if I won the quiz?
Then whoever wins has to feed us breakfast. They pay for the breakfast.
Ever had a winner?
Okay, ready? Do you have the code? Okay, everybody join again, please. Same link. So we have two people joined, 3 have joined.
Oh, we just lost another one.
We lost 2,
Oh, there we
we
are.
have gone up to 5. So we have come to 4.
So Leki, Dolan, Amanullah, Variza, that's all I have. And then Thomas. Where's
Thomas,
Thomas? And Shaikh.
Thomas, Sheikh, and Nida.
Vonkabovic.
They are in, but they're trying to get in. Let's hope they can get in. Any luck, guys? So we give you 1 more minute. You can try. And then if you come in late, it's okay.
Well, the questions are very difficult. If you miss the first 5, you can still win.
Okay, we're up at 5
Okay,
now.
Anthony Thomas has come in.
Thomas, perfect. Now we are missing Shaikh and Wong something. Vonkabovic, I'm sorry. Vonkabovonic.
That's your quiz here, if you can pronounce that right.
The thing is, I wrote it down and then it went away, you know, and I cannot read my own handwriting. So I just see the first 4 digits.
Okay, can we just call and check? If there's not, then we have to get on with it. Oh, Anthony Thomas got disconnected.
I think it's very unstable. That's bad. Did I lose my audio or is it
No,
quiet?
We're all quiet.
Nobody says anything.
Oh, Thomas is back.
Yeah, he tries to double his chances. You see that?
Oh, there's Sheikh. Okay.
Good. That's the best we had. 6 people. That's very good.
We're still waiting for. She's here.
Nida, a new one.
Okay.
A new player coming up here.
Looks like we got everybody now.
Oh, wait. This is too fast now for me.
Okay.
Kanwal, Tariq, oy. And this Wonka boy is not there. Okay.
Okay.
Did you call this person also? Shall we just start?
I think we should start. All right.
3, 6.
Thank you for bearing with us. We have our participants and somebody keeps drifting in and out. Okay, now are they going to, you're going to show the questions on the screen?
Question on the screen. Maruf, you have the questions? Where are you?
I have the questions, but it's going to be really hard to share the pictures off my phone.
No. Somebody should show this. We were supposed to have 2 screens. What happened? Maruf, where are you?
Yes, sir, I have the questions with me. I can share my screen.
So if you share the screen, can we see this buzz-in at the same time?
Yeah, Maruf, you have to share your screen with Bazin.
That's a challenge here.
Look,
Most
Maruf is
difficult talk.
responsible for this. So what's going to happen to Bazin?
Maruf will open. Maruf, open Bazin from on one side.
So it's actually virtual spine, world spine, hippocampus challenge.
Final quiz.
You got it. This is it, folks. Okay.
Can you open the buzz-in, please, on the side? Let's quickly do this.
I hope this is not the answer.
Okay.
Maruf, where are you? Can you tell us what's happening?
Sir, I cannot open it side by side. Only one
If you-
window will appear.
If you minimize you can open two windows simultaneously by minimizing one and then playing with the sizing.
Okay, I will try it.
Maruf, share your screen just, then open the two files side by side.
Okay, that's the way to do it. So don't share, you can show two different windows together. So what we did was to give all the responsibility to Maruf, so poor fellow, I'm sorry. So our
The look
friend
on Noor's face says it all.
Why is the audio so bad right now? What's the problem with this?
You can tell us a joke or something.
No, I have a
Don't.
ugly echo. Ugly echo. On all my jokes, I cannot tell in presence of a woman.
Okay.
Maruf, can you send the slides to Imad? He can do both of them, please. Now, can you quickly send the slides to Imad?
Okay,
Let's
I'm
do that.
sending.
We're running very late. So in the meantime, can Nida
Well, it's
try to join?
difficult questions. If somebody has one answer, he might win. Most of them were prepared by Doug. You know, he's very difficult. You know, very challenging questions.
Okay.
So now we have all the 10. Oh, very good. All 10 have come in now since we delayed.
Well, but I don't know the names then. You have to show me the names.
Yeah,
Otherwise,
we're
I
gonna
cannot
get
count on any
get the
result.
screens up.
Imad already has my questions.
Okay, can you?
Maruf, where are they?
Maruf, where are the questions?
Check your email on yesterday.
What's the subject, Maruf?
I have sent it again.
Okay, he's just sent again. Sorry, guys. This wasn't planned delay. Okay, just downloading. Okay. I have it on side by side beforehand. Get on with it. We don't need that.
Okay. All right.
Wow, thank you.
We're in action.
So somebody called Usman is in now.
Yeah, everybody's in.
Usman. And Wonka thing is gone, but now it's Shirakuma. Okay.
All right.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Oh,
I
10.
have 10.
Okay. And then if
Is
you
it
could
10
do
players, yeah?
slideshow on the.
Okay.
All right, people, it looks like we are finally ready to go. We can just get the full screen on the PowerPoint.
Can we get a full screen? No, we cannot get a full screen. If we get a full screen, Buzz will go.
No, no, but I mean, you can at least go to the slideshow. It's slideshow.
No, I cannot do the slideshow. If I do.
Okay, all right, that's fine then. Okay.
Second slide.
All right, is everybody ready? Here we go. First question. Where was the first World Spine meeting held?
Oh, very difficult.
So, Chirangumar.
No, did you all sleep? Oh, bust. One bust. Okay.
Oh, is Chirangumar's mic on?
And we
unmute you, Mike. Give us the answer.
Yeah.
Hello?
Hello.
Yes.
Yeah, it was held in.
What?
Held in the Berlin.
Berlin, you are correct.
Oh, Berlin, yeah,
Thank you.
that was right.
All right.
Good. You're leading 100.
Next question. Screws at the caudal end of a long fusion of the sacrum should extend as far as possible in front of this point. What is the point? Oh, our same Chirakumar.
Hello?
Yes.
This is a McCord point.
You are correct.
My audio is very bad. What?
Oh,
okay. He was
okay.
right. Okay.
All right. Here we go again. Let's clear everything. Question 3.
Okay. So question 3 is.
The most common incomplete spinal cord injury, Dolan.
Dolan
No,
is not.
Dolan is good.
Are you there, Dolan?
Yeah, he's here.
Dolan, what's the answer?
No.
Hello?
Dolan?
Dolan?
No, he's not answering. Then where is up?
Well, what does that mean if he's not answering? Minus 200 or what? Or we just skip him?
Oh, he disconnected.
You decide.
Okay,
Then
so it
we're
looks like then
disconnected.
it's
He cannot do
Marissa.
anything.
Oh no, Dolan's back.
Dolan is back now.
Dolan, are you there? Nope.
Yeah, he's there, but let me mute him.
Then let's move on to Marisa.
Oh, okay, Varisa,
Central core syndrome.
you are correct.
That sounds very good.
Okay. Next question.
100.
Okay, for next question.
Which decade of life is aneurysmal bone cyst most commonly seen in? Is it Varisa again?
No.
No, it's not buzzed.
Okay, we're gonna clear the buzzers and we're gonna do it again.
It's cleared already.
Okay?
They don't know.
Yeah.
Nobody going to take a guess? Can you show the answer? Slide 9. So it's commonest in the second decade of life. Oh, too late. Okay, we're now going to go question 3, or next question. Who first described the paraspinal muscle splitting approach to the lumbar spine? Rajesh. Oh no, Anthony.
Anthony. Thomas.
Anthony. Okay.
Anthony, are you there?
Yeah, he's here. Yes, Anthony.
Dr. Wiltsey, you are correct.
Yeah, thanks.
100 points. All right.
Okay.
What percentage of patients with pain due to spinal metastasis achieve symptomatic relief after stereotactic radiosurgery? Looks like Barissa was first.
No.
No buzzed.
Oh,
no, Amanullah.
Amanullah.
Sir, more than 80%.
More than 80% is correct.
Very good.
100 points. Question 7. Oh, sorry, let's clear that.
So now.
Okay.
No.
Okay, Juan Elliman. What is the term used to describe decompression in spinal metastasis?
Elliman, who's this?
I don't know.
have it on my list.
There's a bunch of names that are showing up here that aren't on our list.
Elliman is not known. This is number 11.
No, he's not one of the 10 who's supposed to be playing, nor is Fevzi. So it looks like you're up, Amanullah.
Let's go with Amanullah. Sorry.
Amanullah?
Yes.
Your answer?
Sir, it's separation, sir.
You are correct. 2-1, you're at. Okay. Question 8.
Audio is very bad.
We need to clear the buzzers.
Clear the buzzers, please.
And
I
Dr.
got in the-
Igor is another one who would need to be cleared.
Don't remove the players. It's their fault. Just clear the buzzer. That's fine.
Okay.
We don't take them. I have written down the names.
Okay, so I'm gonna
who's Dr.
go on to the question number 8.
Question 8. The nerve root most at risk in an L45 MIS TLIF. Rajesh. You there, Rajesh?
Yeah, he's here.
The L4 root is correct.
100.
Okay. Here we go. Question 9. The most common short-term complication of trans-psoas lateral interbody fusion. Nobody wanting to take a go at this? Oh, here we go. Amanullah.
One second.
I can answer. It's a quadricep weakness, temporary quadricep weakness.
And wrong answer, minus 200.
Oh,
You're back
he's
to
back
zero.
to 0. Oof.
Okay, so
Anybody else want to take a try? Varissa.
You see the danger.
Varissa is not buzzed.
Varissa. Oh, no, you're not
No.
buzzed. No, okay. So we'll show
No.
the answer. Show the answer.
Okay.
It's actually hip flexor weakness. Because you're going directly through the psoas, they all have a degree of hip flexor weakness on the ipsilateral side. Okay, question. We need to clear again.
Yeah, it's clear.
Okay, question 20. Question Next question. Mean arterial pressure in spinal cord injury should be maintained above Chiran Kumar. Chiran Kumar, are you there?
Mean arterial pressure should be maintained between 85 to 90.
Okay, we'll take that.
300.
300 points and in the lead. All right.
Shall I move to the next?
Yeah, well, we got to
sure.
clear
What are
again.
we waiting for? Let's go ahead.
Okay.
Okay, number 11.
Which upper cervical screw trajectory has the highest risk of vertebral artery injury?
Chirag Kumar again?
Chirag.
Yes, Chirag.
Chirag Kumar.
Yeah, hello?
Yes.
Yeah, it is a McGrill technique, transarticular fixation technique.
That's two separate things. Okay, yeah, yeah, transarticular screw is correct.
Yes.
So
You have 400 now. Guys, you have to catch up with him.
okay, here we go again. This clinical syndrome is a triad of short neck, limited neck motion, low posterior hairline. Chirag Kumar.
Hello?
Yeah.
It is a Klippel-Feil syndrome. It's called.
You
as
are
Klippel-
correct.
Oh, he's very
500. Starting to run away with the game. Okay.
So number 13.
Yep. What outcome measure is used to classify degenerative cervical myelopathy into mild, moderate, and severe categories? Gibran.
The MJOA score.
The MJOA score, you are correct.
So who is that? Tariq, yeah?
That was Tariq.
Tariq.
Yep.
Yeah. 100. Very good.
All right.
So number 14.
Question 14. What drug has shown promise in the CSM Protect trial? Youssef Sheikh.
Yusuf Sheikh is not
No, Sheikh is.
on
Sheikh is
Zoom.
one of them. Yep. Youssef Sheikh, are you there?
No?
Yusuf Sheikh has dropped out of Zoom.
Oh, okay. Then it looks like it's
Chirag
Chirag Kumar again.
Yes.
Hello?
Yeah.
Yeah, it is Riluzole. That is a
Riluzole, you are correct.
Thank you.
600. Wow. Good.
Okay, so next one.
Yep. Question 15. In what year was the posterolateral MIS approach to the disc first described? And unfortunately, this was a question from Rick Fessler's talk, which none of you got to see.
No takers.
Doesn't look like anybody's taking it. This answer is going to surprise you. Can you click on the answer? 1948. So this is not new stuff. Okay. Question 16. This surgeon described the safe zone for the extraforaminal approach. Anthony Thomas. Anthony Thomas.
Camben?
Anthony.
Anthony?
Yes.
Camben stone. Camben.
You were right. Parvis Camben and Camben's triangle.
So Anthony is 200, right?
Anthony is now in second place.
Yeah.
Okay. 17. The MIS TLIF was described by, first, Varissa. No?
No.
Who described the MIS TLIF first? Oh, come on, people. This one's easy. Ah, Michael, welcome back. Okay, looks like nobody's a taker. And our answer? Oh, hang on, Verissa. Verissa did buzz in. Verissa, who described it?
Rohinger.
Who?
Dr. Rohinger.
No, I'm afraid not. Minus 200.
Oh, you're negative now.
The answer, show the answer. No. Smith and Foley. Mo Smith and Kevin Foley. Okay, question 18. According to the AO Spine CSRS guidelines, surgery is strongly recommended for what grade or grades of cervical myelopathy? Chirag Kumar.
Hello?
Yeah.
Yes, sir.
Yeah.
This is, hello?
Yes, we hear you.
It is strongly recommended for severe compression.
That is not the correct answer. Minus 200.
Ooh, you make it more interesting now.
Okay, Gibran Tariq. Gibran, what is your answer?
Moderate and severe.
Correct. That is the correct answer. It's recommended for both, Chirag. Okay,
200.
so that was Tariq is now up
Tariq,
at 200.
200, is that right?
Yep, he's now at 200.
Okay, so next.
Right. Question 19. No part of the odontoid line should be above, of the odontoid should be above this line. It's the one that the star didn't come over. If you get one of the two unlabeled lines, we'll give it to you. So Verissa.
The first top, the macro line.
Which line?
The first top on the foramen magnum, the macro line.
I did not. Did anybody get that?
She's describing it.
Foramen, no.
She's
I
describing
have
it.
an ugly ego. I cannot understand.
Hello, hello.
Hello.
What?
Hello. Hello. Here. Hello.
Yes, please.
Okay, we won't remove points for this one because the question isn't very clear. But yeah, the correct answer here is McGregor's line. Okay.
So question 20.
We'll go to question 26 since that question didn't really work. Okay. So go question 20 now, but we'll just do 26 questions since that question didn't work. Okay, a destructive condition that affects the intervertebral disc and adjacent vertebral bodies as a loss of joint protection mechanisms, generally secondary to spinal cord lesion. Verissa, no, nobody's buzzed yet. Oh yeah, no. Verissa.
No, she doesn't buzz.
Okay, Anthony.
Yes, Anthony.
Anthony.
Kodoma?
No.
Oh.
Now back to 0. Anybody? Oh, Gibran.
Yes, 1 minute.
Gibran, are you there?
Yes, Gibran.
Adjacent segment disease?
No, Gibran is minus 200. Down to 0. Anybody else going to take a try? Okay, and the answer is Charcot-arthropathy or neuropathic, neurogenic arthropathy or neuropathic spine. Next question, number 21.
That was a difficult one.
Yep.
This condition or disorder may occur from injury to the stellate ganglia during ACF, is associated with constant severe aching, often burning pain.
No one.
Oh, nobody going to give it a try?
You give them a hint, they'll try.
Yeah, careful now.
Hints aren't, okay. Show them the answer. Reflex sympathetic dystrophy or chronic regional pain syndrome, CREPS. Okay, question 22. The ratio that is the distance from the Bayesian to the posterior arch of the atlas divided by the distance from the Bayesian to the anterior arch. Varissa.
Yes, Varissa.
Is power ratio.
Powers ratio.
Power
Very
ratio.
good, Varissa. You're back to
Marissa
zero.
is back to zero.
Yep.
Is that right?
Okay. Chirag Kumar, what specific type of this disease entity?
Yes, sir.
This is ossified posterior longital ligament. It is a mixed type of the.
You are correct.
Thank you.
So that you could continue playing because you have 500 now.
Okay. All right.
So
Next question. In 1978, this surgeon expanded the concept of facet fusion by using lateral mass plating instead of bone struts. Anthony. Anthony, are you there? Anthony?
He's not unmuted.
Unmute yourself, Anthony.
Unmute yourself. He's in. I see his name.
Yeah, he's unmuted.
Now he's unmuted.
Are you
I don't
there,
know the
Anthony?
answer. No.
Anthony, you pressed the buzzer. You have to answer now, I think. Sorry about this, but you pressed the buzzer. You have to say something.
Do you have an answer, Anthony?
No answer.
I would
No
say time
answer.
up. Time up.
Okay. That's minus 200.
Minus 200, is that right?
Yep.
That's risky. Not doing anything and doing too much.
Okay.
Back in surgery.
All right.
Okay, so
Question
next question.
25.
Okay.
First described by Bell in 1817, then classified into three types by Anderson. This type of occipital fracture is considered most likely to be unstable and require surgery. Varissa.
Yes, Varissa.
Type 3.
Type 3, that is correct. Varissa's back at 100 points.
So
One
question
more
number 20.
question. This is it, folks. Your chance to move up.
Okay.
These two, and you have to name both of them, occipitocervical segments have both the greatest and the least amount of rotational motion, and you have to name them in order. So the greatest motion first in rotation and the least.
Not looking good.
Scared everybody off.
Not looking good.
No.
All right.
We're at 10 seconds.
Okay, that's it. So show them the answer. So C1, C2 has the most rotation. O1 has the least. All right. So we have a, oh, wow. So our winner is Chirag Kumar, but we currently have a tie for second. So we're going to need to do 3 more questions with just Varissa and Lackey. being
Nice,
able to answer.
nice.
So can we go
Larissa
back to
and
the
Raj
screen? 2 more
Lecky.
questions.
Okay.
Because we need to break the tie between second and
Go,
third.
go back to the screen.
Yeah, 1 second. Yeah, I'm on the screen.
So Rajesh and Varissa are the only people who can answer for the next 3 questions.
Yep.
Okay? So,
Yeah, 1 second.
Oh, nice. You can remove the other people.
yeah.
Very good.
Mike, I bet you would want to do that sometimes.
Exactly right.
So 2 are Rajesh and Varisa.
So, right, yeah, just Rajesh and Lucky and Varissa.
How many are there? Is it really possible to remove them all? I mean, if there are hundreds.
Yeah, okay, so
Okay.
we can start. We can
All
consider
right,
only.
here we go. So we're going to do 3 questions to decide who gets second place. All right, next question. In this stress strain curve, B, C, and CD represent which zones? Doesn't look like any of them is going to grab it.
Chirag.
Close.
Okay.
I am very disappointed.
All right.
I knew you would be, Ed.
10 seconds, Doug.
Yep. So it's the elastic zone and the plastic zone. Okay. Next question. The rate things are going, you just need to answer one. These surgeons reported the first series of patients operated on using a ventral transthoracic approach for Pott's disease. Okay.
10 seconds.
Okay.
All right,
It's 10.
and the answer was Hodgson and Stock. We would have taken either of them. Okay, this is it. This is your last chance, people. One of you's got to take a flyer here.
Okay,
Go big or
so
go
next
home.
question.
All right, here we
these
go. The
Joker
last
questions are
question.
very difficult.
In the 1950s, Sperling, Scoville, and Seyerberg championed what approach for lateral disc removal?
Okay.
You can't win if you don't take a chance.
Take
All
a
right.
pick. Which approach?
That is
If you
15
don't
seconds.
try, you're both third.
Okay.
Okay, as
Nobody
a
gets-
punishment.
There you go.
All right.
That is good.
We will do one more question in the hopes that we can have a winner.
Maybe have a question which has no history in it.
Okay, question 60. Who described the first lumbar pedicle screw?
History is difficult here.
Oh, man.
Okay, Joachim, who described it?
I don't know. I'm very bad in history. I'm lucky that I'm just a juror. I don't have to answer these questions and participate.
Anybody gonna take a guess? Show them the answer. Harold Bucher.
Oh.
And no, he did not pronounce his name Boucher. He pronounced it Butcher, not Boucher. All right, this is it.
So it's
Last
obviously a
possible
question you
chance.
selected.
Otherwise, it's 2 third
Toss.
places and a first place.
So one more, I think then they're all
Yeah.
third.
Okay, here we go.
Okay.
This benign aggressive tumor arises as a remnant. Oh,
Rajesh.
Rajesh was first.
It's a chordoma.
You
Chordoma.
got it. Our second
right.
place winner. All right. Thank you, everybody, for taking part.
Very good. So what is next on our schedule? I was, this was.
So just announce the top three, man. Just
Sorry.
announce.
Our top three then, our winner is Charan Kumar. Our second place is Rajesh Laki, and our third place is Varissa. Congratulations.
Brilliant.
Okay.
You did okay.
Okay, so for our next session, I'm gonna request Professor Paulo Pereira and Professor Liliana Angelov to conduct it.
Thank you, Nurlan. Thank you, Nurlan. Now it's my pleasure to introduce Professor Edward Menzel from Cleveland Clinic, who will give us a glimpse on how he foresees the future of spinal surgery.
I've been given a lot of ammunition yesterday and today, and I am going to take the liberty to maybe go over a minute or two here. So please excuse me. In the United States, the national pastime is a sport called baseball. And in the 60s and 70s, there was a catcher for the New York Yankees named Yogi Berra. And he was also sort of a comedian. And he said, "I hate to make predictions, especially about the future." And that's what you're asking me to do, and I will go ahead. I think the future of spine surgery resides in 4 arenas: technological advances, resource utilization, allocation, operative indications, and the advancement in spine care delivery. Regarding technological advancements, we have total disc arthroplasties, dynamic fixation, artificial facet joints, biologic imaging advances, MIS, robotics, and on and on. We can just see the explosion of all of this happening. And it has been stated that this is the future of spine surgery, but I question that. Is the tail wagging the dog here? How many advances can society reasonably absorb as costs climb and efficacy potentially declines? We talk about cost effectiveness, and an individual procedure may be cost effective, but if it's widely used, is it affordable by a society? I take a step sideways here. This is a highly stenotic spinal canal, a CT scan. Can you see my pointer?
Yep.
Okay. With the stabilizing part of the facet joint being medial, and if you take off too much of that, the prevention of translation cannot happen. So folks have developed minimally invasive strategies to deal with decompressions. And here we see a minimally invasive approach where the contralateral approach side was decompressed effectively, but in order to effectively decompress the ipsilateral side, excessive facet joint needed to be, or it didn't need to be, but was removed. And so I asked the question, and we must really separate true minimally invasive surgery from minimal incision surgery. That last operation I showed was a minimal incision and maximally invasive operation. We also have to question operating on patients that may be treated more effectively otherwise, and maybe the most minimally invasive operation is either a weight reduction operation or no operation at all. And dealing with complications, as we see here, can be horrendous problems. Also, the surgeon here may have lost an opportunity to cause this patient to change their lifestyle and lose weight, hoping that the surgery would fix their problem and not deal with probably the major aspect or causative agent in the patient's problem, which is the weight. So most research that's published these days is conclusion-based research, research that is designed to prove a point and not process-based research. The first is frequentist-based on frequentist probability, and the later is exploratory inquiry based on Bayesian probability. Fundamentally, with conclusion-based research, the literature is flawed, and there is a mounting amount of studies that demonstrate that early findings are not sustained. Here we see most published research findings are false, and the truth wears off. And the now famous Scott's parabola demonstrates early participation and the utilization of a technology, then the truth wears off, and we end up without not using it. The trouble is, the area under this curve may represent a significant expenditure of money and injury to patients. So there's all sorts of bias that go into the research: surgeon-based bias, patient-based bias, selection bias, study design bias. But with conclusion-based research, the studies are usually bias-laden, with the bias all in one direction. And with exploratory inquiry, there may be bias, but they're neutral. The different biases going in different directions, neutralizing each other. So the second part is research utilization and allocation. We know that in the United States, certain spine operations have a 10-fold difference in per capita utilization from region to region, and regions sitting right next to each other in our country. We most certainly see resource maldistribution in the world as we face problems worldwide. Operative indications. How do we really assess our patients? Are we studying patients with health-related quality of life metrics? And can AI, artificial intelligence, or machine learning help us sort out who to operate on? Unfortunately, many patients that we operate on have, instead of a surgically treatable problem, have a chronic pain syndrome. Chronic pain for more than 3 months, non-restorative sleep, low energy level, inactivity, 24/7 pain, and on long-term opiates. The phenomenon or the clinical entity that we can operate on is mechanical back pain, deep and agonizing pain worsened by loading, improved by unloading. But oftentimes there is a pseudo-concordance, an apparent but erroneous relationship between an assumed cause, i.e. an imaging study, and an effect, back pain. If a patient has a chronic pain syndrome, but also has an L4-5 spondylolisthesis, and keep in mind, L4-5 spondy is an imaging finding. It is not really a diagnosis. The clinical diagnosis would be chronic pain syndrome or mechanical back pain, for example. And if the patient gets an operation who has a chronic pain syndrome, that is shame on the physician. So you can ask questions. Have you had pain? Have you had low energy level? Do you sleep okay? Do you spend most of your day laying around? Do you suffer? Do you have pain in more than one part of your body? In other words, multiple unrelated somatic complaints. If many of these answers are true, you may be wanting to think about not operating on a patient with degenerative strategies. So we ask patients, well, we do have foundational strategies to deal with them. Active treatments, weight loss, as in that lady I showed earlier, exercise, cessation of smoking, etc. And then there's passive treatments like pills and laying there and saying, doctor, treat me. So core strengthening, flexibility, smoking, cessation of weight loss, these are all lifestyle changes. Unfortunately, at least in resource unchallenged areas of the world, people are standing in this line that are overweight smokers, unwilling to do lifestyle changes, but more than happy to receive pills and surgery. So can artificial intelligence and machine learning and big data help us? Maybe. We know that with 1 and 2 level decompressions, that there is 40 to 80% of the patients at our institution miss the MCID on functional and quality of life outcomes. And on average, only 60% of them reach their MCID, which means that we're not as good as we think we are. And we need to rethink how we think about selecting spine surgery. And then advances in spine care delivery. We need to start with people from all over the world, not just North America or Europe. Here is an article from Dr. Jha in a resource-challenged area of the world who couldn't afford operative instruments. So he goes to a shop and makes micro-dissecting instruments. This is ingenuity. This is innovation. So all the technologies that we talked about, most of the technologies that we have talked about address first world problems, degenerative diseases of the spine. But what about what happens in middle and low income countries? I think we're getting there a little bit. Education, distribution of resources, communication through venues such as we are experiencing here today, the World Spinal Column Society, World Neurosurgery, World Federation of Neurological Surgeons, etc. I thought, and I think Paulo must have shared my comments with Dr. Munting, but he gave a great talk yesterday, I thought, on affordable spine care worldwide. Is it a dream? Can we leverage technology to address middle income and low income resource inequities? We just heard Michael Wang say yes. It's going to take time though. I think he mentioned maybe not in his lifetime. So this morning I got an email and I got from Dr. Munting and I asked if I could share it with you all. He says, I thank you for your nice comments following my recorded presentation to World Spine. I felt a bit old-fashioned without praising robots and many fancy and fantastics techniques available nowadays. But I'm convinced that the right indication, in particular for surgery, remain the most important point in our endeavors, still too often neglected. I hope the message will get across to our younger colleagues. Hope to meet you sometime in the future when King COVID-19 allows us to travel. I think we need to seriously heed and contemplate his words. So yes, we can do education and distribute resources and communicate. Our world is indeed getting smaller and smaller. And I believe that that is the true future of neurosurgery. Instead of focusing on what we do as a commodity or a job, we should focus on what we do as a labor of love and a calling. We should focus on what we do not as how much we do, but but the good we do, volume-based versus value-based care. And industry, a la Michael Wang, must participate. We cannot ever hope to perform a $500,000 operation in the vast majority of the world. And a screw is a screw. We need to work on getting industry to participate. COVID-19 isn't all bad. It has enhanced the utilization of technologies like Zoom, et cetera, for communication and education. And this in turn can't help but facilitate the redistribution of resources, in particular human resources and education, but hopefully down the road, technology and supplies. The better we know each other, the more effective we communicate and the more effective we can be at distributing all of these resources. And so I'd like to leave you with a comment by Machiavelli. There is nothing more difficult to plan, more doubtful of success, nor more dangerous to manage than the creation of a new order of things. Thank you very much.
Ed, thank you very much for once again an excellent and very thorough presentation. At this point, I'd like to invite Ed Benzel and Mehmet Zaleli to present the winners of the oral presentations. I think all the presentations were excellent. We had a very tough time choosing the winners, and the winners are listed here.
Yeah, we are coming to the end.
Where are they listed?
Yeah, we have the list.
I have the list. Do you?
Yes.
Yeah, I have sent both of you the list.
Yes, I have it. It's right in front of me, but Lily just said that the list was shops. Oh, am I still on screen share? Okay, there we go. At any rate, Mehmet, do you want to list the winners?
Okay. The first three who has been chosen for the best presentations, I will give the first, the number 3. This is Dr. Nishank Mehta from India. Design and implementation of an enhanced recovery after surgery, ERAS protocol in elective lumbar spine fusion by posterior approach, a retrospective comparative study. This is the number 3. Number 2 is, probably I can give all, and then Ed will tell who have they won, what are the awards are. Number 2 is that Dr. Pang Hung Woo from Singapore, thoracic endoscopic laminotomy with bilateral decompression using one block resection technique, and thoracic open laminotomy with bilateral decompression for thoracic ossified ligamentum flavum. Number 1 is Dr. Wu Xiang from China, treatment options of cervical spine fractures with ankylosing spondylitis and their clinical efficacy, a national multi-center study.
Congratulations to all.
Yeah.
Okay, I'm sorry, I had a minor crisis here. The third and second place winners receive a 2-year World Spinal Column Society membership and the official World Spinal Column Society textbook. All 3 of them do receive that. And the best paper, Dr. Zhang receives in addition, will get free registration to World Spine 9 in Korea.
Great.
Yes.
Congratulations.
Congratulations all.
All 3.
Hey, I'm nice.
Going off.
All right. So for the next part of our program, for those of you that know Salman quite well, you know that he is an exceptionally gracious individual. And as his first mandate as our new president, he has asked us to present certificates of gratitude to our speakers and moderators for the entire meeting. So a very, very special thank you to all these recipients. Imad, can you show the slides?
Okay, so the first one, so we'll start with Professor Michael Fellings from the University of Toronto, Canada. Can you go on?
Next, we'd like to thank Zia Coughlin, who is the Julius Stoll Professor and Chair of the Department of University at the Warren Alpert Medical School of Brown.
Professor Nikolai Konovalov from Burdenko Neurosurgical Center in Moscow, Russia.
Edward Munting, Professor and President of the Eurospine Society, Head of the Orthopedics Department, Clinique Saint-Pierre, Belgique.
Professor Zhen Shen from Department of Neurosurgery in Beijing, China.
Professor Richard Asseker, Professor of Neurosurgery, Regional Neurosurgery Hospital, Lille, France.
Professor Michael Wang from Department of Neurological Surgery, University of Miami, United States.
Atul Goyal, Professor and Head of the Neurosurgery Department at the King Edward Memorial Hospital in India.
Professor Edward Benzel, Founding President of the World Spinal Column Society and Head of Neurosurgery Department, Cleveland Clinic, Ohio.
Professor Yanis Polytheodorakis, President up to yesterday of the World Spinal Column Society, Scientific Director of the Athens Brain and Spine Surgery, and Visiting Professor in Crete.
And now our current President of the World Spinal Column Society, Professor Salman Sharif from Karachi, Pakistan.
Mehmet Zaleli, past President, World Spinal Column Society, Chairman of the WFNS Spine Committee. Paulo Pereira, Secretary, World Spinal Column Society, Head of Spine Unit, Department of Neurosurgery, Hospital Center, São João, Porto, Portugal.
Amjad Shah, Consultant Neurosurgery from Coventry, UK.
Jose Antonio Sanchez, President of the Mexican Society of Neurological Surgery, Vice President of the Latin American Federation of the Neurological Societies, and Chairman of the Spine Clinic in Mexico City.
Little managed to give his talk, so we'll hand over to Professor Douglas Hart from Cleveland Clinic, Ohio, US.
Professor Sait Naderi, immediate past President, World Spinal Column Society, Chairman of Neurosurgery in Istanbul, Turkey.
Professor Sandeep Vaishya from New Delhi, India, who is currently the Treasurer of the World Spinal Column Society. Professor Lidiana Angelov, Vice President of the World Spinal Column Society, and working in head section of spine tumors, Department of Neurological Surgery, Cleveland Clinic, Ohio.
Michael Steinmetz, Professor and Chairman, Department of Neurological Surgery, Cleveland Clinic, Ohio.
Professor Abdel Fattah Saoud from Egypt, Vice President of Education and Student Affairs in Ain Shams University and past President of the World Spinal Column Society.
Joachim Ortel, Professor and Chairman, University of Saarland, Omburg.
Yang Sung Kim from Nanuri Hospital, Gangnam in South Korea.
Vasilis Likomitros, Orthopedics Department, Aristotle University of Thessaloniki in Thessaloniki, Greece.
Nikolai Pev, Consultant Neurosurgeon from Belfast in Northern Ireland.
Ruli Dalan, Head of Neurospine and Peripheral and Pain Division, Department of Neurosurgery at the Medical Facility of Padadharan University in Indonesia.
Ajit Krishnani from neurosurgeon in Cleveland Clinic, Ohio. And I think this concludes our list of certificates for speakers, moderators, and guest lecturers.
So now, to wrap up the meeting, I have the privilege to invite our next speaker to close our first virtual World Spine meeting. Professor Salman Sharif needs little introduction, as he has worked tirelessly for many years for the World Spinal Column Society. And this, combined with his truly visionary approach, and perhaps more importantly, his profound and belief and support of the educational mission of our society, has made him a role model and a true hero in the spine world. Salman, we very much look forward to a very bright future during your presidency. Thank you.
Thank you, Lily and Paolo. I think it was overall a great job from everybody. And this wrap-up is not the wrap-up of the society. It's actually the start of another era in the society. I think we all need to work at a different level to get the society going. I think what has happened over the last couple of days is something like what we're seeing on this screen on the left side, where you see this is a Baltor glacier that we have next to K2. And this is the most amazing place. And, you know, once you go there, you don't want to come back. So it's something like that we have in our society. We have all the friends who are very closely knit. So, you know, we talked about fun, and you can see Greg Trost having this glass on top of his head. And Doug trying to cut a cake with the help of these swords, or us in a wedding, in Nicolay's wedding in his hometown. So, you know, all these places have been amazing. This Coventry Spine Masters. So it's all about fun. So we had the virtual challenge, and I think preliminary round was brilliant. There was some hiccup in the final round, but still we got there and had a lot of fun. So this is from the prelim round that we took this picture, and everybody enjoying and having fun at that time. Obviously here we had the world leaders in spine care who gave us amazing talks. Really enjoyed it, and you know, everybody listening carefully, having a lot of fun, education at the same time. And I see in this picture, Paolo and Christina both present in this picture. So husband and wife attending the same meeting in the same picture is amazing. And then obviously everybody else enjoying the show as well. And Michael Feeling was listening to the talks as well in the afternoon. Again, all the keynote speeches were brilliant. All of them were superb. What the World Spine Executive Board and the whole gang did here was amazing. Everybody loved it. The audience was really, you know, spellbound by the quality of the knowledge that was given to them. Supporting hands, and this is really all the guys who chipped in at every end. You know, small things, big things, everybody contributed. Whoever we asked for help was there, ready to contribute, and you know, everybody wanted to give a big hand to us, and it was amazing. To start out, it was just a small dream, but slowly and gradually, we realized that you know, we can do this. This is actually our guys in our own hospital who helped us all along, and you know, having a birthday party last week, in my clinic. And again, you can see Joachim trying to dance. I don't know what he was trying to do there, but and then you can see Janis, Greg, and Doug sitting down on a boat in Karachi, in one of our Karachi spines. So as Ed said, it's all about learning, but with fun. And that's what we have done over the years. And this is our family, our society that we have worked for. And we'd hopefully take it to a different level altogether. As we are about to close, I'd request all the people who are here, you automatically become a member, honorary member of the society by attending this virtual World Spine. And then you can become a permanent member within 6 weeks by going and getting a 30% discount on the membership, which will be enabled on our membership website. So you can see, you can go on worldspinalcolumn.org and go into members. And if you click on members, you can see the benefits and click how to become a member. And there are loads of benefits which are there. And especially with the book coming up as well, you have free access on top of it. There's free access to world neurosurgery as well that comes with it. So guys, you know, the whole thing was brilliant. I'm grateful. Everybody throughout the globe have done wonderful job for the society. Thank you very much. Lily?
Thank you very much, Salman.
Hello.
Thank you very, very much. And we're gonna make a group photo again, correct?
That's correct. Can we all switch on our videos, please, so we have a group photograph, and can we all smile, please? It's difficult to continue smiling for a while, but let's try. Ruli, you can smile, it's okay. Please switch on your videos. Okay. Sandeep, you can smile as well. Sandeep thinks that his video doesn't work very well. You can smile, it's okay. Okay, are we done?
Yes.
No. Okay, we are done. So who's going to wrap this up? Maybe Ed again, I'm going to say the last few words. Where is that gone? Yes, Ed.
This has been great. It's the world getting smaller, coming together, solving problems together. I think we can do it. We can redistribute resources. We can learn from each other. We can teach each other. This is a great forum for this. Thank you all. And I must admit that some people heard me doubting this a month or so ago, and y'all have pulled it off in a fantastic way. Thank you.
Thanks.
Okay,
Sandeep,
thank you,
and
everybody.
you in particular.
Sandeep,
I
wanna
think
say a
you
few
were
words?
aggravated with me at times.
I have to just now go and operate on a COVID positive patient.
Okay, guys.
And that kind of sums it all up.
Thank you all for all participants.
Thank you.
Thank all the participants.
Thank you, everybody.
Thank you, all the
All right.
participants.
Thank you, everybody.
Okay.
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 Bye-bye.
Cheers.
Bye-bye.
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 Thank you. See you at World Spine 9.